Distinguished guests, esteemed colleagues, and valued attendees, it's so good to see you all here on this warm Sunday morning. On behalf of the organizing committee, Eternal Hospital Jaipur, it is my immense pleasure to welcome you all to Rajasthan's first exclusive Eternal Cardiac MRI Symposium 2024. I am Dr. Ankita Gupta, Assistant Professor in the Department of Radiodiagnosis, SMS Hospital Jaipur, and I am honored to be your host for today's symposium. We have an exciting lineup of speakers and sessions that promise to enrich our understanding and practice in this relatively new dynamic subspecialty of radiodiagnosis. It is now my privilege to introduce a special video presentation by Dr. Sameen Sharma, sir, Chairman, Eternal Hospital, Jaipur, Director, Mount Sinai Cardiovascular Clinical Institute, and Director, Interventional Cardiology, Mount Sinai Health System, New York. Sir unfortunately couldn't be with us in person today, but he has graciously prepared a message for all of us.
Hello, everyone. Greetings. I am Dr. Sameen Sharma, Director of Cardiovascular Clinical Institute, Mount Sinai Hospital, New York, and Chairman of Eternal Hospital, Jaipur. It gives me great pleasure that Eternal Hospital, under direction of Dr. Ritu Agrawal, is conducting the first MRI Symposium of Rajasthan. As you know, Eternal Hospital has established a reputation of a tertiary center, providing excellent care in all aspects of cardiology, and the MRI, the CT are no exception to it. We do large number of these procedures every day. And in order to advance this field, we are organizing a dedicated one-day symposium in which all the relevant topics by the experts will be discussed along with the case reviews. As we always want to advance the field, can only be done by these dedicated mini symposia and conferences. And I'm sure you'll be very happy with this one-day symposium, which will take place on June 23rd at Holiday Inn. So please come, join it, and it will be very useful for you. And we'll also show you some of the cases live on the MRI computer terminals. Good luck and see you there. Hello, everyone.
Thank you, sir, for the warm welcome. I now request Dr. Mahipal Singh, sir, Director and HOD, Radiology at Eternal Hospital, Jaipur, to deliver the welcome address. Sir has more than 20 years of experience in radiology and has special interest in cardiac imaging. I can kindly request Mahipal Singh, sir, to come up on stage.
Good morning, my dear friends. Welcome to the Rajasthan first Eternal Cardiac MR Symposium. It is an honor to have such a distinguished gathering of experts and professionals. I think we will share a common passion for advancing the field of cardiac MRI. In an era of where technology innovate, continually reshape the landscape of medicine, cardiac imaging stand at the front foot, offering the invaluable insight into the heart health and disease. Today, we come together to explore this advancement, exchange knowledge, and inspire one another. Over the day, we will dig into the groundbreaking research, cutting-edge technique, and practical application of cardiac MRI that are transforming patient care. Our esteemed speaker, renowned for their contribution to the field, we share their expertise and vision for the future. We will have the opportunity to engage in the thought-provoking discussions and hands-on workshop session designed to advance collaboration and innovation. I would like to extend my heartfelt thanks to our sponsor, organizer, and volunteers whose dedication and hard work had made this symposium possible. Your contribution ensure that we can continue to push the boundaries of what is possible in cardiac MRI imaging. As we embark in the journey together, I encourage all you to full advantage of the opportunities presented, engage with your peers, challenge your perspectives, and be open to the new ideas. It is thought our collective efforts and shared knowledge that we will continue to drive progress and improve outcome for the patient care worldwide. Thank you once again to join us. Let's make this symposium inspiring and impactful for all of us. Thank you.
Thank you so much, sir, for the kind words. Now it is my pleasure to invite Dr. Ritu Agarwal, ma'am, Associate Director, Cardiac Imaging at Eternal Hospital, Jaipur, for opening remarks.
Thank you, Dr. Ankita. A very warm welcome to all of you. First of all, I would actually like to thank all of you for being here on this Sunday morning, where you could have been easily sleeping or doing something else. So, from Rajasthan to people who are not outside Rajasthan, Khambagani, a very warm welcome to all of you. The cardiac imaging is basically the newest modality when we go to radiology. The imaging of a beating heart has been always a challenge. And only till recently, when we have developed the newer scanners, we are able to successfully do so. And therefore, it's the new kid on the block. And we are trying to tame that kid. And I hope you all will have a joyride here. You'll enjoy the process, understand, learn, explore, and discuss. And by the end of the day, I do not mean either of you would be an expert. Honestly, even I am not an expert. But I still believe that we as a team could spark an interest so that at least some of you would take cardiac radiology forward. Now, when I'm standing here, I remember the years when I had not done the fellowship, and I really understand what all of you might feel. Kaise hoga, kya hoga, it's too hard, it's very different. I understand all of that because I've been there. But trust me, you got to start somewhere. And only when you start, only when you push yourself, then things change, and they change for better. So in Eternal Hospital, we have a dedicated team of cardiologists, CTVS surgeons, cardiac anesthesia, and cardiac imaging. Last year, we performed 575 cardiac CTs and 227 cardiac MRs, which are the highest in our state. And the symposium is a commitment to knowledge sharing, to academic excellence, and to allow more people to start cardiac imaging. Now, I would just like to conclude with what Roger Federer said recently. Effortlessness is a myth. You practice, and you practice more. It's only one case. He said one game, but I'm saying a case. Even if you get it wrong once, twice, you still go on till you get it right. Good luck.
Thank you so much, ma'am. Without further ado, let us commence the sessions. And after each presentation, there will be a brief Q&A session where you can engage with our speakers. To chair the sessions, I invite Dr. Anu Bhandari, ma'am, Senior Professor, Department of Radiodiagnosis, SMS Hospital, Jaipur, to kindly grace the dais. Dr. Jyotsna Sinha, ma'am, Senior Consultant Radiologist at Getwell Diagnostics, Jaipur. And Dr. Vijay Bhaskar Nori, sir, Chief Radiologist and Managing Director at Vista Imaging and Medical Center, Hyderabad. Thank you so much, ma'am. Thank you, sir. Please join me in welcoming our first speaker, Dr. Ritu Agarwal, ma'am. Ma'am is Associate Director of Cardiac Imaging at Eternal Hospital, Jaipur. She's the only radiologist with 2 dedicated US fellowships in neuroradiology and cardiovascular imaging in the entire northern India and in Rajasthan. And she is also a level 3 certified cardiac radiologist from Society of Cardiovascular Magnetic Resonance, USA. Ma'am will be sharing insights on cardiac MR planning and indications.
Very good morning to all of you. So today's first talk would be on CMR planning and indications. Okay. So CMR is basically the one-stop shop for various cardiac disorders. And the advantages of CMR over other non-invasive modalities are its accuracy, its reproducibility, which means that you can go back to the scan and see it again. It has unrestricted field of view. There is no ionizing radiation, and its ability to characterize myocardial tissue, and its safety profile in renal diseases. Now, these are all the sequences that we have for CMR. We have a functional sequence or cine images on which we can look and calculate the EFR. These are the stress and the rest perfusion images on which you can look at ischemia. That is a scar imaging where you can look at the scar. These are the mapping sequences which give you an estimation of the myocardial edema and fibrosis. And this is a stir image where again you are looking at myocardial edema. And in the next few slides, I'm going to talk about all of these in further detail. So before we go to the sequences, we talk a little bit about a question. So respiratory artifact reduction. So what do we do for that? We first have to do a breath holding, and therefore we scan during expiration. The reason being because during inspiration, there is increased movement of the diaphragm, and therefore they are changing, it might need to change in the position of the heart. And if the patient is unable to breath hold, then sometimes the system has a navigator technique, so we can use that as well. Now, for reduction of the, for removal of the artifact from the cardiac motion, we have to use a ECG gating, and we synchronize the equation along with the cardiac rhythm. This can be done either as a prospective gating or a retrospective gating. This is how the leads the position on the Philips scanner. And these are some of the precautions that you must take while using the leads. So you should not use the ECG signal for monitoring or diagnostic purposes. You use only MR-safe electrodes. There should be a proper skin contact. Do not use expired electrodes. Do not reuse the electrodes. Do not use pediatric for adult and adult for pediatrics. And we should not place the ECG battery module directly on the patient's skin, for there's chances of skin burn. And we should not place the battery module close to the imaging volume because there might be artifacts from that. Now, these are the sequences. So we have a standard cine, white blood and back blood. Then we have the cine images, which we do in vertical long axis, which means a two-chamber view, where you see the left atrium and the left ventricle. Then you them on a short axis view, on a four-chamber view, and a LVOT view. In all of these, the slice thickness is around 7 to 8 mm, and the gap is 3 mm. Then, if required, we do a perfusion sequence with rest, and we stress it with adenosine. In this, we take just 3 short axis slices, one at the base, another at the mid, and at the distal. Some people like to do it the apex if required. Then we do the flow studies, traditionally for the aorta and the pulmonary artery, sometimes for the SVC and the pulmonary vein. A T1 scout image after giving contrast, and then the late gadolinium enhancement, the LG images for short axis, 2-chamber and 4-chamber view. In this, the slice gap is 0. And if you have thrombus, then you have to do a long TI time where more than 600 milliseconds, because it is only a thrombus that will stay black on a long TI. And then sometimes if your software is equipped with a mapping, then you want to T1 and T2 mapping. Now, the first thing is you have to do a localizer sequence in a coronal, axial, and a sagittal image. This can be FSIP, FFE, or Feaster, depending on your scanner. And it is a very fast and is a question time of less than 25 seconds. So it quickly does the localizing. Once you come to this is how you have taken from top to bottom an axial image. And then you have to position your cursor in this such a way that you come to the middle of the mitral valve. Then you angulate it in such a way so that it is cutting perfectly across the left atrium and the left ventricle. And once you do that, then you get your two chamber. So you get this two chamber from that scout image. Now you have to scan from the top to bottom of this two chamber view. So you get a four chamber. Here, this is the left atrium, left ventricle, right atrium in the right ventricle. This is incidentally a mass in the right atrium. We are not talking about this as of now. Once you get your four chamber, then from the four chamber, you go from top to bottom and you get your short axis. So this is how short axis. Remember, for the short axis, your plane of alignment should be in perfectly parallel to the mitral and the tricuspid valve. And you take at least a few sequences, one or two sequences in the atria. And then from the atria, you go down towards the cardiac apex. So once you do that, you get this short axis. And the short axis is a powerhouse of your cardiac MRI scanning. Because on this short axis, you will be doing your volumetric analysis. On the short axis, you will be looking at the wall motion anomalies. Although everything is important, but I would say sometimes patient do not breath hold, or there's a problem with the question, or the patient cannot lie down on the scanner for the full 40 minutes. Then I first always take a short axis. If short axis अच्छा आ गया, PSIR अच्छा आ गया, at least the report will be diagnostic. Then from that, you do a LVOT view. You go to the base of the heart and you align your cursor in a way that you are crossing the mitral valve and the aortic valve. From that, you get a three chamber and also make a LVOT view. Now, when you cut across the aortic valve, you'll get a flow, which I'll show you in the next sequence. Then you can do these additional sequences. These are not mandatory. We usually take a stir with every patient. However, the mapping sequences is only when you have a software, and T1, T2, we do if we have a patient of cardiac mass. Now we give contrast. After contrast, we run a Dixon image or any volumetric scan for the angio. And then after that, we do this T1 scout. So the purpose of this T1 scout is to select the appropriate nulling time when. So just let me play this again. So this is, okay. We have to come to a place here at this image where the myocardium becomes black and the cavity recovers. So that is the appropriate T1 time on which we are going to take a post-contrast images. So something like this, when you have the myocardium is black and whatever is this scar will come out white. In this particular patient, the scar is in the pericardium. You can see this circumferential white signal in the pericardium, which shows that this patient probably has pericarditis. And then on this, we do a scar mapping, which is the software does it automatically and give you the volume of the scar present in the myocardium. So functional analysis, you do the LV function. For that, you have to, when you put your short axis in your software, it will automatically contour the endocardium, as in for the left ventricle is red, and the epicardium, which is in green. You have to scroll through each slice to see that the contouring is correct. If something is wrong, you check it manually, but mostly it does that on its own. So the property here is that we consider that both left ventricle and right ventricle are cylinder. And then we cut them into discs. And then we calculate the area of each disc, we sum them, which will give you the volume. So that is the principle behind it. You don't have to do anything. The system does that all on its own, which we'll show you in the workshop if you have registered for that the endocardium and epicardial contours are drawn, and then map is generated for the EF. And even in the right ventricle, similarly, the yellow is the endocardial border and the blue is the epicardial border of the right ventricle in a similar way. So in a similar way, this sort of map comes on your console once the volumetric analysis is complete, and you can have the EF stroke volume, cardiac output, and end-diastolic volume, systolic volumes, etc., all displayed for use. Now for the scar burden, again, if your software is equipped, it will divide the myocardium into these segments. And once it does that, it will calculate the volume of the scar. So in this, the total muscle mass is on the top is about 113, and the scar mass is about 44. So about 39% of the myocardium is scarred. Now, these are how you take flows. If you align your sample volume along the aortic route, then you get this perfect image of the aortic valve. And in a similar way, for the RVOT, you get the pulmonary artery. So when you use this, you get the flows of the aorta. And when you use this, you get the flows of the pulmonary artery. So once you have that, then you put them on your, again, on your application. And you just have to draw this red circle. Once you do that, the system automatically calculates this map and will give you the total volume, out of which what is falling back will be the backward volume. Then the net volume which is going will be the total minus backward. And then the volume of the backward over the total volume will be the regurgitant fraction. So regurgitation is basically, ideally, whatever the heart pumps. For example, the LV, whatever it pumps should go into the aorta. But that doesn't happen. A part of it is falling back. So what is the part falling back? That is the regurgitant volume. Okay. So this is done. You have to just draw this circle and these values comes up. Now, most of it is automatic. But the point is, whenever it is doing something, you should be well versed with the applications and the principles. And if something is wrong, then you redo your counters and see if the system is not doing it correctly. These are the mapping sequences, and you have newer softwares of strain evaluation, which we again show you in the workshop. Now, the indications of cardiac MR. So the CMR, the most important indication is cardiomyopathy. So it will help you to group the patient in two major groups for the purpose of treatment: ischemic cardiomyopathy and non-ischemic cardiomyopathy. So in ischemic cardiomyopathy, the goal is always to assess the viability. Because if the myocardium is viable, they'll do a PTCA or a bypass. And if it is non-viable, then they'll put the patient on optimal medical therapy, which is OMT. And if the patient doesn't have an ischemic pattern scar, then he may have all these conditions, which are non-ischemic in one broad group, non-ischemic cardiomyopathy. And we'll go step by step on how how MR helps in these. So now in ischemic cardiomyopathy, how will CMR help? So CMR will first show you the scar. Now, okay, why this is going back? So for the scar, these may be three potential scenarios what you have. As I said, the black myocardium is normal. Whatever is white is the scar and abnormal. Now, in this case, if you look at these red lines which I have drawn, this white is essentially, if you consider the whole myocardium as full thickness and you divide it into 4 segments, then this white is approximately 1/4 or 25% of the entire thickness. So this is 25% thickness. This is about 50% of the myocardium is white and 50 is black. So it is 50% thickness. And this is about almost 100% of the myocardium is white in this area. So it is 100% thickness scar. Now, why this is important? Anything 50 and less than 50 is viable, and anything more than 50 is non-viable. Basically, 50 and 75 are dicey, that you'll get with experience. But if it is less than 50, then you are sure that it is viable. And then based on that, you calculate your scar score and transmurality. So transmurality is the number of segments having more than 50% thickness scar. All these numbers actually help the clinician to take a better idea of what they should do with this patient. Now, sometimes within the scar, you see a black spot, small or large. That is the area of microvascular obstruction, which means it is a no reflow phenomena where no contrast will reach despite delayed images. And this is a poor prognostic marker. These patients have more risk of arrhythmias, and they have to approach these patients cautiously. And then it will also show a LV apical or a thrombus wherever it is present. So an ischemic cardiomyopathy will tell you whether the myocardium is scar. If it is scar, it is viable or non-viable. If it is scar, it has microvascular obstruction or not. And if it, whether or not there is a thrombus and what is the size of the thrombus. Now, sometimes you are asked to do a stress perfusion. So what is stress? Stress will do all that which we were doing on the previously, but it will also detect ischemia. Now, the difference between ischemia and the scar is the ischemia is the myocardium, which is at risk, which is ischemic, but it will recover if you revascularize completely. However, the scar is the patient, scarred is the myocardium that is completely gone, will not recover. So to detect ischemia, you give adenosine. You first take a resting image and then you give adenosine and you rescan the patient. And on a adenosine ischemic image, you see these kind of subendocardial perfusion defect. Now, if you look at this image, this subendocardial perfusion defect is there. However, on this post-contrast images, we do not see any scar in the corresponding area. This is the inferior wall of the LV, and on this image, I do not see a scar. So that means this area is ischemic, but this is not scarred, and this is the target where we are looking at. So this patient will not have any symptoms at rest, but when he gets some stress, he might develop a MI, and these are the patients we are looking to. However, if the patient is subendocardial ischemic defect and you get a scar in the corresponding territory, then this patient is scarred. Now, even again, this scar is less than 50%, then we consider the myocardium as viable and we still revascularize. So that you have to keep in mind. Now, when a patient has a hypertrophic heart, okay, just one, why this slide is moving constantly? I just want to state here, it's automatically going to the next slide. इसको automatically next slide पे क्यों जा रहा है ये? हमने So when you have a hypertrophic heart, myocardial hypertrophy, which is seen on echo, then the basic questions arise is whether it is really hypertrophic cardiomyopathy or it is hypertrophy due to other causes. It may be athlete's heart where the patient is doing some sort of intensive physical activity and there is enlargement of there is hypertrophy of the right atrium, left atrium, and the ventricles. Or it is hypertensive cardiomyopathy with a myocardial hypertrophy secondary to hypertension, or it's a aortic valvular disease leading to concentric LV hypertrophy, or it is a amyloid, or it's a pical SCM. So MR will show all these conditions differently and therefore is very useful. Now, if we establish it is a case of hypertrophic cardiomyopathy, then we have to know whether it is obstructive versus non-obstructive because the management will change. Then exact end diastolic thickness is important, and because that has prognostic value, which can be well seen because you can play the slices and go to the last end diastole, which is possible only on MR and not on echo. This is one very important advantage of MR over echo. Then you can also calculate the function, exact function, and you can calculate fibrosis. Now, the end diastolic thickness, if more than 30, and if the percentage fibrosis scar more than 15 to 20% in the myocardium, then they are an indication that these patients actually have a very high risk of arrhythmias and sudden cardiac death, and therefore we have to put ICD in these patients. So when a patient of hypertrophy comes, the physician wants to know whether it is HCM or it's just hypertrophy due to some other cause. And if it is HCM, then what is the end diastolic thickness? What is the pattern of scar? How much scar he has? Whether they can manage it conservatively or whether they want to put ICD and send the patient home. Now, when you have amyloid patients, again, suspected amyloid, the patient might be suspected of amyloid on echo because he has biatrial enlargement and some dilated, some thickened ventricles, but the function is more or less normal. So what will MR do? Why we do MR in these conditions? Because we want to first calculate the accurate ejection fraction. We can do a strain imaging using the strain software. And if this strain shows the apical spheric, then it is a case of amyloid. Then we can also confirm the diagnosis without biopsy and without contrast because we have a T1 mapping. So if on T1 mapping, the T1 value is raised with the morphology suggesting amyloid, then you can make a conclusive diagnosis of amyloid without doing a biopsy for the patient. So this is the value of MR in cardiac amyloid. Now, if a patient who has irregular rhythm, then the patient, again, they want to know what kind of infiltrative cardiomyopathy it is. If it is sarcoid, it's ARVD, it's myocarditis, or it's DCMP. So in all of these conditions, MR will show different picture. So if a patient is suspected sarcoid, he will may have some reduced function, but more or less normal. Size also do not change a lot, but you'll see these lymph nodes in the actual images, and this pattern of scar mid-myocardial to subepicardial, and the scar is mostly on the insertion points, the superior and inferior RV insertion point, and goes and involve the adjacent RV as well. So when you have this hook sign, this scar going from the LV to RV, you know you're dealing with a patient of sarcoid. Now, when they suspect sarcoid, if you do not get a scar, this patient has very low incidence of ventricular arrhythmias and sudden cardiac death. And if the patient doesn't have scar, then it essentially rules out cardiac sarcoid, and no further workup for cardiac sarcoid should be done. So what it means, patient comes with arrhythmias, cardiologist को लगता है sarcoid है, they send for MR पे scar नहीं है, so that means it is not sarcoid. They should find out some other potential cause for arrhythmias. And the patient can stop their workup for cardiac sarcoid. Now the patient, if suspected RA-RV dilated, then ARVD becomes a diagnostic possibility. So then again, we do a MR. On MR, we can see this dilated right atrium and right ventricle. On a cine image, you will see some microaneurysms, which I cannot show on this image. And on a post-contrast images, sometimes you may find a scar. Now, ARVD means arrhythmogenic right ventricular cardiomyopathy. So sometimes it has LV involvement, and therefore now we have renamed this entity as a arrhythmogenic cardiomyopathy. So there may be involvement of the LV with scar in the LV. So we have these numbers. So we calculate the volumes, and if the index volume for RV is more than 110 and the ejection fraction is less than 40, then this is two major criteria for diagnosis of ARVD, or sometimes we have one major and two minor criteria. So depending on the volume. So one, it will establish the diagnosis that whether the patient has ARVD or not in a case of dilated RA-RV. It will also differentiate it from other cardiomyopathies such as sarcoid, because the pattern of scar will be different. Myocarditis, again, there will be no edema, pattern of scar different. Athlete's heart, dilated cardiomyopathy, RVO, TVT, and Brugada syndrome, which essentially do not have any scars. So in all these conditions, you may have dilated RA-RV. So MR will tell you what is the cause of dilated RA-RV. Now, once you have a diagnosis of ARVD, you have to also screen the family members because there is some genetic predisposition. And again, if you have a normal MR, then it is almost 100% certain that the patient doesn't have ARVD and they can go back home. In case of myocarditis, we have to look at the stir sequence, which shows edema. On an early gadolinium enhancement image, we show some scar. And on a late gadolinium enhancement image, we shows again some scar in a non-ischemic pattern. So when you have this, the diagnosis of myocarditis is confirmed. And again, then the management could be tailored accordingly. For a DCMP. Now, DCMP is a very wide term. It just means the myocardium, the LV is dilated and the EF is slightly down. And it can have a heterogeneous differentials possible. For example, in this case, this is an old lady, and you can see this, all the chambers are dilated, but only the base is contracting, and the mid and distal segments are not contracting at all. If you look at eyes on this plane, this part is moving, and this is all ballooned out. And then on the scar image, there is no scar. So this was a patient of the Katsubo or a broken heart syndrome, and this resolves on its own. The non-compacted myocardium is thickened, and the ratio of non-compacted to compacted is increased. So this is the case of non-compaction myocardiopathy. This is the case of bundle branch cardiomyopathy. So basically, in all the cases of DCMP, MR will differentiate whether it is a ischemic versus non-ischemic cardiomyopathy, and therefore will guide to patient's therapy. For example, if it is ischemic, then you have to revascularize. If it is non-ischemic, then you probably have to give medical management. If it is myocarditis, you have to give some immunosuppression or antiviral therapy. So the management of the patient will change based on the MR findings. Then again, prior to implantation of CRT, if the patient shows scar on CMR, then these patients might be unresponsive to cardiac pacing, and therefore use of CMR is indicated. We can accurately determine EF pre-treatment and on follow-up imaging. Then you can also see intracavitary thrombi, and therefore you can stratify the risks for these patients. Now, NSVT is a very common indication for MR. Because primarily we are looking at the pattern of scar and see what kind of cardiomyopathy it is. And if on these you find these ring pattern scar, where you see a near circumferential scar on post-contrast images, then these patients have a high risk of malignant arrhythmias. And This means that the patient most likely has a genetic cardiomyopathy. So you have to screen the family members. You have to closely follow up these patients and put a ECD for prevention of future events. So that was cardiomyopathy. Now, why we do MR in pericardial diseases? So again, echo is the first line. CT is done for calcium. But what does MR tells you? So MR, on the basis of stir image, if you see this edema in the pericardium, the white circumferential line you are seeing around the heart, and you see a similar circumferential enhancement on a post-contrast image, then you know you are dealing with a case of acute pericarditis because it is pericardial edema with enhancement. And this is the same image I showed in myocarditis. Sometimes with pericarditis, you have myocardial involvement as well. So it will show you if it is perimyocarditis. And sometimes you do not see any edema and enhancement, but you see some degree of some thickened pericardium, and you see these conical deformity of the ventricles and some restraint. So this is a case of chronic calcific pericarditis. This I have a case on the workshop, so I'll show you details there. So basically, MR will tell you if there is pericarditis or not. And if it is pericarditis, is acute versus chronic, because acute will manage with medical therapy, and chronic will, if it is calcified, then they need to do the pericardial stripping. And the surgeon will not touch the patient till the edema and the inflammation has subsided. So again, MR is very important. And you must be very precise on your report that what they are asking for. Now, again, for a cardiac mass, the patient, you have to answer 3 basic questions, whether it is a mass or not. If it is a pseudotumor, if you are seeing a crista terminalis or a dilated coronary sinus or some pericardial cyst. If it is a mass, if it is a thrombus versus a mass, that is the most common question for a mass on a CMR. And also vegetations, because vegetations are small, they are seen attached to the valve. So often MR will not help this except under certain rare circumstances, because here a T is better because the size of the vegetation is very small. It's less than a centimeter. And because of the quick movement of the valve, sometimes the MR will not pick up. But thrombus versus mass is a very common question. So you have to see if it is a thrombus or it's a mass. And if it is a mass, what is the morphology? What is the extent where it is sitting? If it is benign versus malignant, to guide the treatment. And if possible, a differential diagnosis of the mass. So these are a few pictures. So this is the case of apical thrombus. Now, why it is a thrombus? Because it will stay black even on a 600 Ti MS. And it will not pick up contrast in any circumstances because it is a thrombus. It is avascular. This is the case of myxoma. On a post-contrast image, you see the enhancing core and a non-enhancing cap, which is the thrombus. The thrombus which is sitting on the top of the myxoma. This is a fibroblastoma, which is a very small nodule seen on the aortic valve. This is the case of rhabdomyosarcoma on a young child, and that is a cardiac mets. You see these white enhancing spots in the myocardium, and this is the lung mass which was there in this patient. So this patient came for a lung mass, and some abnormal LV function was there, and we did a cardiac MR and we found these enhancing areas within the myocardium. So this is cardiac mets. Now in congenital heart disease, MR is very important. It will tell you the LV size and function, the RV size and function. So in congenital heart disease, keep in mind that the small children, the young children, they'll always be done by echo, because echo is a very good modality in them. The windows are very clear, but as the baby grows, and if once they have a surgery, then the echo is not that useful because there will be some artifacts, and then the MR comes. So the CHD patients will be mostly adolescent or adult CHD, which is coming for follow-up, and the clinician wants to know if there is what is the function, and these patients see now if the patient has PR, they have to fix the valve, pulmonary regurgitation. If the patient is pulmonary stenosis, they have to fix the RVOT, but then these patients might require recurrent surgery. So you have to give an exact estimation of the EF and the pulmonary regurgitation to decide the time of the surgery. It's important. If the patient can still go on with the same EF for some 6 months or 1 year, then you delay the surgery accordingly. And therefore, accurate estimation of the size and the function is important, which will be done on MR. Then you can calculate the regurgitant fraction using flow volumes. So we'll quantify PR, which will decide the time when you want to replace the valve. Then you can calculate the Q flows in the pulmonary artery, aorta, and the branch PM. And with this, you calculate the QP, which is the flow in the pulmonary artery, to QS, which is the flow in the aorta. And the ratio will give you if there is any residual shunt. Ideally, QP-QS should be 1. The flow in both sides of heart is equal. If there is a mismatch, then there is either a left to right shunt or a right to left shunt. which will be seen. So in the patient of repaired ASD, VSD, PDA, then you calculate the QPQS to see if the defect is closed and there is no residual shunt. Now, if you have to also calculate the flows in the right and the left pulmonary artery in some cases, if there is a branch pulmonary artery stenosis. So for example, if the left pulmonary artery is stenosed, then that will, left lung will get less flow and that left lung will become smaller in those patients. So you have to calculate the flow. And at appropriate time, they have to fix it. They have to put a stent to open up the pulmonary artery. And again, you can see the anatomy. You can see the RVOT because that is the site of surgery in most of patients. So if there is any aneurysm formation, if there is any pulmonary artery stenosis, and if there is any collaterals. For example, in this patient, this is a repaired CHD, and you can calculate the volumes during the epicardial and endocardial border. This is the LPS stenosis, very well seen on a post-contrast image. This is how you would do a flow and calculate the regurgitant volume. And this is a repaired TOF where there is a RVOT aneurysm at the site of prior surgery. So what does CMR offer beyond diagnosis? It allows a risk stratification, example in patient of SCM. It allows in planning of treatment as in patients of CHD. It allows a non-invasive follow-up for all patients with congenital problems such as ARVD, genetic cardiomyopathy. It allows an improved understanding of the pathophysiology of the disease. It allows screening of the additional family members, and overall it reduces mortality and morbidity of the patient. So the high cost of MR is justified, and whenever required, we should and must do cardiac MR. So the take-home message is that with tissue characterization and evaluation of cardiac function, CMR has provided unique information for diagnosis of various cardiac diseases. The common indications are ischemic and non-ischemic cardiomyopathy and the different subtypes. We discussed pericardial diseases, tumors, and congenital heart disease. And now we have developed faster sequences to bring down the scanning time. There's increased awareness and paying capacity in the patient, which will further improve its utilization in future, and therefore we must all be aware of it. Thank you so much.
Thank you so much, ma'am, for the wonderful presentation. We can now take any questions from the attendees for ma'am. You can raise your hand and we'll bring the mic to you. Okay, so now we proceed to our next speaker, Dr. Suman Singhal, ma'am. Ma'am is Director of Cardiac Imaging and Head of Department at Mahajan Imaging, Fortis Escorts Hospital, Jaipur. Ma'am has 24 years of experience in radiology, academics, and administration, and is trained in cardiac MR at Mount Sinai Hospital, New York. And ma'am will be delivering talk on cardiac MR in ischemic heart diseases.
Hi, good to see many familiar faces. So how many of you are doing cardiac MR or the first timers or starting from the basic? Can you raise in how many are doing cardiac MR as such? Okay, great. I can see in one hand. And so rest of you are basically, we are going to try to start doing cardiac MR at our institutes. I guess so. See, I would like this session to be very interactive. So coming after this wonderful lecture by Dr. Ritu on the cardiac planning and indications, I will be talking about CMR in ischemic heart disease. And I would like to thank Dr. Ritu, my prior hospital, Eternal Hospital, Manju ma'am, and the organizing committee to have me here for this lecture. So coming to ischemic heart disease, as Ritu said, it is very, very important to evaluate or to the role of, if we talk about CMR in ischemic heart disease, because depending on this, they were going to decide whether they should revascularize the patient or not. So it is just not only the viability, we talk about the cardiac anatomy and function. In echo, you all know that we are doing the eyeballing. So gold standard is cardiac MR to assess the cardiac function of LV and RV both by the myocardial tissue characterization, that is a late gadolinium enhancement, which we call it LGE. We can decide about the scar, the infarct, the size and all, and we can decide whether it is a significant CAD or not. Then by the stress perfusion imaging, we can look at the myocardial ischemia. whether it is reversible or not. And by the newer MRI methods like parametric mapping, it helps us to look at the edema, fibrosis, and the places where we are kind of stuck between ischemic, non-ischemic, and all that. The parametric mapping is of a great help. So coming to cardiac MR as such, so we can see the infarcted myocardium, we can look at the viability, we can do the scar quantification, we can look at the MVO or the no reflow phenomenon, function, perfusion. Even for the long-term follow-up of ICM, it is very good. And per se, the advantages of MR as such that it is non-invasive, no ionizing radiation, can be repeated, and the images are reproducible, can be evaluated later on by multiple people also. So what is viability, what we talk about? Myocardium in which the contractile function is expected to improve or in which remodeling can be avoided once the blood flow has been restored. So that is viability. If we talk about in a layman language, if we see a akinetic myocardium or a hypokinetic myocardium on echo, whether it is viable or non-viable. So non-viable, no, nothing needs to be done. Patient goes for medical management. And if it's viable, we do revascularization of the patient by PTCA or a cabbage. So what are the key non-invasive methods to do the viability? It is not just cardiac MR. It is echo. We can do a DSC, SPECT, PET, and CMR. If we talk about the different modalities comparison, cardiac MR stands as a very good place. It is much better than SPECT, and it is equivalent to PET at certain places. The spatial resolution of cardiac MR is very good. And in fact, in SPECT, you can miss the small subendocardial infarcts as we are seeing here. This is the CMR images showing the small subendocardial infarct, same on the histopath, and on SPECT they were not seen because the spatial resolution of CMR is better than SPECT. The predictors for CMR are that we look at the ejection fraction, MVO, which is not a good prognostic indicator. We can look at the, sorry. We can look at the valves, we can look at the complications. So many times we get these CMRs for the aneurysm planning. If the patient already has a aneurysm, thank you so much. So to exactly know how big is the aneurysm, where is the neck, how wide is the neck, whether there is myocardium around it or not. So for planning of surgery also we need a CMR. So this is just a brief thing which I think Ritu already talked about, that by the T2 weighting imaging, we look at the function, by the T2 weighting, we look at the edema and all, and by the stress perfusion, we look at the ischemia, and by the LG or the delayed enhancement, we look at the scar and the MVO and all. We do the cardiac function. I'm again talking, it is very good, it is quantitative. This is by the circ image, but on the Philips system, we'll show you in the workshop. The wall motion, very, very important when you are seeing at the viability. The people who are doing echo are much familiar with it, but even the radiologists, once they start doing it, they are able to see. So this is a place where we are getting the hypokinesia of the septal wall. This is a normal way the LV, RV are moving. This is a 4-chamber view showing the normal wall motion. And this is the function we take the short axis tag. So to look at the hypokinesia or akinesia wall motion, very, very important. So this is how we are seeing the valves. This is just an aortic valve we are seeing. This is a bicuspid aortic valve. You can see the fish mouth appearance. And this is how a tricuspid valve will look like. We do the flow measurements, calculating the QPQS as well as the regurgitant fractions on the CMR. Now, end wall thickness and diastolic wall thickness is very important in viability. If we are seeing the end wall thickness more than 5.5 to 6 millimeter, most likely this myocardium will be viable. Because usually in the chronic infarcts and all, if it thins out less than 5.5 millimeter, most likely it will be non-viable. And per se, we don't call it on our reports viable or non-viable. We call it probability of recovery. So if it's like, less than 75% or something with enhancement, which we talk about, we call it very low probability of recovery. And on a good scan, we call it very high probability of recovery. So never put the words viable or non-viable as such on your reports. So end diastolic thickness, if you're talking about less than 5.5 millimeter is a criteria for myocardial necrosis. And on PET, that is a very low metabolically active myocardium. If we talk about sensitivity and specificity of EDT for the diagnosis of viability, it is 72 to 89%. So you see the importance of it, that if you see a hypokinetic or akinetic myocardium on the echocardiography and CMR, and you find that the end diastolic thickness is very well preserved, then very likely this myocardium will come back. That 4% were found of these segments were found to be viable. So this, I think she's already talked about how do we take the localizers and the black blood images and how do we plan the sequences. For viability, so we take the cine for function, we do the T2 weighted for edema mapping, we do the rest perfusion if required, and then we do the DSC or the late gadolinium enhancement. These are the LVOT, RVOT view, the mapping sequences, Q flow, these are the extra sequences. If we talk about only viability, we can finish the scan just in 20-25 minutes, taking the basic sequences. Stress MRI, if we do, then we are doing with the adenosine stress perfusion. And in this, we take both the arms, we take the cannula, and the smaller cannula is for adenosine, the larger cannula is for contrast. We put the BP cuff in the arm where we are putting the contrast, and then we do the adenosine stress perfusion. In the same, after 10 minutes, we do the DSC, the late gadolinium enhancement, and then we give the contrast again after almost 20 minutes of the stress, and we do the rest perfusion. Now, very, very important sequence for viability in a ischemic heart disease, delayed enhancement or the LGE, which we call it. This is taken 7 to 10 minutes post-GAD. These are usually the inversion recovery sequences. We can take with the breath hold, and if the patient is not able to be breath hold, then even we can do the free breathing single shot sequences. And the rule is bright is dead. Means whatever is enhancing is non-viable. It is dead myocardium. Normal, stunned, or hibernating myocardium will be dark or will not take any contrast. So there were a lot of trials were done, and they found that LGE, that is a late gadolinium enhancement, CMR, and PET and SPECT were equally effective in determining the myocardial viability. And there, in fact, in the patients where there is not a good window and arrhythmias are there, in these patients, LGE, CMR is in fact better than DSC. In a normal clinical scenario, usually the cardiologists are doing the DSC, which is very, very good in evaluating the viability. So LGE CMR is superior to DSC in these scenarios. And they found that LGE CMR has highest sensitivity 95% and specificity in predicting the regional wall motion improvement after revascularization. Depending on the enhancement pattern, when you're doing the LGE, you can differentiate between an ischemic and a non-ischemic cardiomyopathy. My dear friends, Dr. Priya and Dr. Noori will be talking about the non-ischemic cardiomyopathy later by the hypertrophic and all. So if you're seeing a subendocardial infarction or a transmural infarction, that is a ischemic cardiomyopathy. So on CMR, when there is when they're not sure about the cardiomyopathy, by the enhancement pattern, we can definitely say whether it is ischemic or non-ischemic. Look at the subendocardial infarction or the transmural infarction. If it is like, circumferential subendocardial like this, or patchy mid-wall or epicardial, we know that we are dealing with a non-ischemic cardiomyopathy, and we divide it further depending on the enhancement pattern. So there is an inverse relationship between the transmural extent of hyperenhancement and the likelihood whether the wall motion recovery will happen after revascularization or not. So if in the anterior wall, like this patient had problem in both the LAD territory and the RCA territory, and we did not see any enhancement on the LAD territory, that is the anterior wall. So this is most likely viable, or a more likely that the patient will be recovering in this. And this is a transmural infarction in the enhancement in the inferior wall. So very low probability of recovery in the RCA territory. So this is how a less than 50% enhancement will look like. And this is kind of transmural enhancement totally will look like on a CMR. Now, stunning and hibernation. You must know this because by the cine imaging and delayed enhancement imaging, one can differentiate between stunning and hibernation. Stunning is basically in the acute setting, and hibernation is in the chronic setting. So stunning is that once the patient has atypical chest pain, he has stenosis, you have revascularized the patient, but the wall motion is not coming back. So you want to know by CMR whether, if the viability is there or not. So if we find that there is less than 25% or 50% enhancement, most likely these segments will come back. But, I'll show you one case also. In hibernation, this is in the chronic setting, that chronically it is stenosis artery, but the myocytes inside the myocardium are in the sleep mode. So they are very viable and they are likely to come back. So once we evaluate the viability by that, we know that it is a hibernating myocardium which will come back by the revascularization procedure. So here we are seeing that there is an inferior wall MI, that there is a hypokinetic inferior wall here. On the delayed and contrast enhancement, it is less than 50% enhancement, which is there. And after 4 months of follow-up, you can see how the contractility has come back. So this is how, this is stunned myocardium. This was a case of acute MI. So this is how the CMR helps us to evaluate this. To put it broadly, if the myocardium is without any LGE and in a patient of ischemic cardiomyopathy, the probability of recovery is very high, around 80%. If the delayed enhancement is between 26 to 50%, recovery is 60%. If the higher enhancement, as I said, if the higher enhancement is there, it is very, very low recovery will be there. So patterns of transmodality of infarction, this is just to show, like first image, there is no enhancement, very likely to be viable or recover. Very little enhancement, 1 to 25%. Again, this very likely to will recover. This is like 25 to 50% enhancement, then less chances or moderate probability of recover. More than 50% or more than 75% transmural, very, very low probability of recovery. So after this lecture, you should know that you have to look at the thickness of the enhancement in the myocardium. At least that much point is like taken care of. And we follow this 17 segment model according to the territorial distribution of the coronary arteries. The red one is your RCA, the yellow one is your LAD, and the blue one is your circ. So this is a pattern or a bullseye, which we call the 17 segment model, and we calculate the viability of the enhancement on this 17 segment model. So according to the current guidelines, the CMR can be used even for the risk stratification in the chronic coronary syndrome patients. So patients who have more than 2 segments out of the 17 segments on a stress perfusion defects, or more than 3 dobutamine-inducible dysfunctional segments, these patients are likely to benefit from the revascularized patient even in a chronic setting. So various studies are going on, and they have found that LGE along with the, they call it multi-parametric CMR, like we do a multi-parametric prostate and all that. So that is cine imaging, LGE, rest and adrenaline stress perfusion. It is much better than SPECT for a high diagnostic accuracy in CAD. This is how a LAD infarct will look like. This is your anterior wall, this is LV apex, and this is your anterior wall, anterior septal wall, anterior lateral wall infarction. So this is how a LAD infarct will look like. This is how your RCA infarct will look, the inferior wall, inferior lateral wall. Here we are seeing the enhancement, the subendocardial enhancement, and this is a RCA infarct. So no reflow phenomenon, where these are the areas. This is first see this image. These are the areas when you will see this black area surrounded by this enhancement pattern. So this is a MVO or the no reflow phenomenon. So what is MVO, no reflow phenomenon? This is failure of blood to reperfuse a ischemic area, even after the physical obstruction has been removed or bypassed. So these are the areas which are not likely to recover even if you do a revasc. So these are the areas which look like dark core surrounded by the enhancing rim, and they represent a damaged microvascular in the core of the infarction. So whenever you see a no reflow phenomena or an MVO, which we call about, it has a worse functional outcome. They are prone for LV remodeling and an adverse clinical outcome in these patients. So these are the MVOs, or the no reflow are usually seen in the acute infarction. So whenever you see the MVO, you know this is an acute infarction. This is not a chronic infarction. And we see even the edema in the T2 weighted images. So this is how a MVO will look like. I think we have a case also of MVO in our workshop. So coming to a case, this is a 45-year-old male presenting with acute chest pain. On CAG, there was LAD 90%, LCX 40, RCA 30. On echo, there was a regional wall motion abnormality in the anterior septal and anterior wall. Moderate LV dysfunction was there, no clot vegetation. MRI was done for ischemia and viability. So what do we see? So whenever you are evaluating the stress and rest, you should keep together the images of basal, mid, and umbilical together with the same kind of windowing and the brightness and all that, so that you can see the defects very well. If you can appreciate, these are the rest images and these are the stress images. There is a subendocardial perfusion defect which is there in the mid and the apical wall here, the mid and the apical slices along the anterior septal and the anterior wall. There was a regional wall motion abnormality, as we talked about, very hypokinetic anterior septal wall and the anterior wall. On the contrast imaging, there was not much of enhancement seen at all. So this was a reversible myocardial ischemia in the LAD territory. And when the patient underwent a PTCA for the LAD, this was the image for that. And later on, after 6 months, we can see how the anterior wall motion abnormality has improved. We can see the contractility. So this is how the CMR makes a difference in looking at the cases. So if it's a normal thing, you will not see defect anywhere. If it's ischemia, you will see stress perfusion defect, but no rest perfusion and no delayed enhancement. If it's an infarct, you will see a stress perfusion defect as well as a rest perfusion and delayed enhancement. If it's a peri-infarct or the area which is kind of reversible, you will see more than the delayed enhancement, the areas in the stress and rest. So this is another patient, 56-year-old patient with the atypical chest pain. What we are seeing, normal wall, this four-chamber view and the short axis view, there is a definite hypokinesia along the inferior wall. There was not much of edema on the T2 weighted images. On the stress and rest, we are seeing that there is a definite subendocardial defect which is seen along the inferior and the inferior lateral wall. On LGE, there are these areas of enhancement subendocardial along the inferior and inferior lateral wall. Again, this was a reversible ischemia. Another important thing once you will be seeing is a dark rim artifact or a this. So this you have to differentiate from a stress perfusion defect, because dark rim artifact, if it's there, it will be like very thin, less than 1 pixel size. This will be there in the starting. It will not stay for a long. A normal perfusion defect will come after the myocardium has started enhancing, and it will stay for a long time, for much more like RR intervals than in the this dark rim artifact will disappear after some time. And this will come before even the myocardium has started enhancing. So one has to differentiate between a dark rim artifact and a actual stress perfusion artifact. This was a TVD on CAG, co-dominant system, LAD mid 100%, LCX 90 to 95, RCA 95, mid RCA 100%. So this is how you are seeing the whole myocardium is enhancing, and again the MBO which we are seeing here. So, and we are seeing the LAD territory as well, the LGS territory as well as the inferior wall. So everywhere we are seeing the enhancement. In the LAD territory, it is more than 50%. This is likely to be very less likely to be viable. And in the RCA territory and all, it is moderate probability of viability is there. And this is how we calculate the function and the scar quantification which we do. And depending on the segment, so we give the segment ratio as well as we give the percentage ratio of the enhanced volume which is there. So it is considered that if it's more than 25% enhancing volume, it is a bad prognostic sign. And I went through a lot of literature. So they say if with your more than 7 segments are kind of not viable or a very low probability of recovery, these patients will not benefit much from the revascularization procedure. So they should go for a medical management. So these are the complications of a ischemic cardiomyopathy. Here we're seeing aneurysm with the thrombus here. And this is again aneurysm with the thrombus it is non-enhancing, very black thrombus surrounded by an enhancing wall. So this was the LAD territory infarct with a thrombus, another large thrombus. For tiny thrombi, echo, they cannot pick it up. For tiny thrombi, CMR is the place where we can see it. So many times it has happened that we have seen the 4 to 5 milliliter clots in the LV apex, which were not picked up an echo, and we found it later. So other complications are, this is how our inferior wall aneurysm is looking like. And we can see the other complications are ventricular septal wall rupture, lateral wall rupture, severe MR, which can happen. So these are the complications of a ischemic cardiomyopathy. So this I was talking about, that you have to look at the neck, the size of the aneurysm before the aneurysm repair planning is done. CMR now has a role even in the plaque assessment. They say that, I think all of you must be doing the temporal arteries, that even plaque assessment which we do now, that if you see a high T1 weighted images in the coronary plaques, it correlates very well with the vulnerable plaque. Though we are not doing in the coronaries, we are doing in the other arteries, the vessel wall imaging, which we call about, but it is the role is still coming up of CMR even in the plaque assessment. MR coronary angiography, few images we found beyond CT, MR coronary should not be done. CT is a very good with a very, very low spatial resolution, which we have, and it's very fast. Parametric mapping has a role to play when we cannot distinguish between a ischemic and a non-ischemic cardiomyopathy. So we do it with T1, T2 mapping and ECV. It has helped us at many times to differentiate between the two. Even the MI will have raised values of T1 and ECV as we see it here. These are T1 enhancement LG image, and this is a T1 mapping. So they were raised T1 values were found. Minoka, this I would like to thank Priya for giving me this case. So CMR has a role to play in Minoka, that is myocardial infarction with normal, no obstructive coronary arteries. So if you perform CMR within 7 days of presentation, and in nearly 90% of the patients with acute chest pain and elevated troponin levels and non-obstructive coronary arteries, you are able to find a cause for it. So thanks to Priya for this case. So 58-year-old male with hypertension, diabetes, non-smoker, rest angina. On ECG, there was STEMI. So high troponin, CAG was normal. On CMR, they found that there how the parametric mapping helps actually. So there were these raised values in this inferior lateral wall, and there was, anterior lateral wall here, and there was you can see a subtle enhancement is there. So review of catheter angio was done, and they've confirmed occlusion of a small OM branch. So CMR helps in this cases of Minoka as well. So nowadays, what they're talking about is a rapid CMR for IHD, that you just don't do some 1-2 hours of CMR, just going on and on. For you can just do a 20 minutes or 25 minutes of scan with just cine, your function, and your contrast, the LG, and if required, the stress perfusion. Try to finish it off fast, and you can assess the viability. So these are a few chapters. So thank you so much. We would like the questions later or now only? हाँ बोलो. So they are more than 75%. So like, a lot of literature we went to, because if we say like these many segments, the cardiologist or the cardiac surgeon still wants to go ahead with the revasc, and they want to know whether the ejection fraction of the LV will improve or not. Yes. Because it is, severe 20%, 25%. And we are saying, so, I went through a lot of literature to find it out what is the cutoff limit. So we found that if it's more than 7 to 8 segments, like, then if we talk about the enhanced volume, it comes more than 25%. So those are the cases where it is less likely that the ejection fraction will improve even after the revasc. So you put the ball in their court, only you tell them this is what it is, and that is again, they have to decide.
Yeah. Okay. Thank you, ma'am. Thank you so much.
Not to improve ejection fraction, but they can still do revascularization to prevent death because of arrhythmia or,
I know the call is on their court only. We can just provide them with the details. Like, they have to decide, because that is why we put the word very low probability of recovery. So we don't know, we know still some myocytes might be there and it might recover. So we just do our bit on the part. Thank you so much.
Thank you so much, ma'am, for such an illustrative presentation. I now request our chairpersons for the closing remarks on these sessions.
I think with Dr. Moody here, nobody else should be speaking. Certainly, I have anything to say regarding these two talks.
Nothing better than both the speakers were excellent. Victor and Suman, but they gave the entire detail. You can't ask anything better than that. I hope all the delegates are well versed with the basics of cardiac mass, because what we have tried to tell you is a bird's eye view of most of the things. So I think you should go and learn the basics and then pick up from there. So they are giving you an excellent presentation of liability and overall bird's eye view of liability. Thank you.
Thank you.
Thank you so much, sir. Thank you, ma'am. It is now time to express our gratitude to our esteemed chairpersons. I now invite Dr. Meenu Bagratta, ma'am, Senior Professor, Department of Interventional Radiology, SMS Hospital, Jaipur, to kindly felicitate our chairpersons. I request Dr. Anu Bhandari, ma'am, Dr. Jyotsna Sinha, ma'am, and Dr. Vijay Nori, sir, to be on stage. Dr. Nori, sir. Jyotsna, ma'am. Thank you, sir. Thank you, ma'am. Let us proceed with our further sessions on cardiac MR. And to chair these sessions, I invite Dr. Meenu, ma'am, Senior Professor, Department of Interventional Radiology, SMS Hospital, Jaipur. Dr. Kirti Rana Chaturvedi, ma'am, Head of the Department of Radio Diagnosis, SN Medical College, Jodhpur. And Dr. Priya Chudgar, ma'am, Senior Cardiovascular Radiologist at Jupiter Hospital, Mumbai. Thank you so much, ma'am. Moving on to our next speaker, Dr. Vijay Bhaskar Nori, sir. Sir is presently Chief Radiologist and Managing Director at Vista Imaging and Medical Center, Hyderabad. Sir has 34 years of experience in radiology with special interest in adult and pediatric cardiac imaging and AI in cardiac imaging. And sir will be illustrating cardiac MR in hypertrophic heart diseases.
Again, switch off this light. Yeah. Good morning, all. After the, I thank Dr. Ritu and entire organizing team for giving an opportunity to share some of my experiences in CMR imaging. I thank all the faculty also for having done a great job, especially the first two speakers, Ritu and Suman, have done a fantastic presentation on their respective topics. My presentation today for next couple of minutes will be on CMR in hypertrophic heart, CMR in LV hypertrophy. Even before that, let me ask you, how many of your consultants, raise your hand, please? How many of you do cardiac MR regularly, every day one? Okay. How many of your IACA members, please raise your hand, please? Association of Cardiac Imaging. Okay, that's good. Thank you. Thank you very much. This light. अच्छा, ठीक, एक बंद नहीं होता. ठीक, okay. So Let us start with the presentation on CMR in LV hypertrophy. So definition of LV hypertrophy. What is LV hypertrophy? First, it is abnormal enlargement or thickening of the heart muscle. Now, if you look at the heart muscle, myocardium, there is what is known as, there are cardiomyocyte and extracellular matrix. So every organ has cells bound by an extracellular matrix. If you take liver, there is, if you take most of the structures, most of the solid organs, there is hepatocyte with matrix, cardiomyocyte with matrix. So a hypertrophy, LV hypertrophy, includes both thickening of the myocyte and the matrix. Remember that point, because imaging will tell you what is what, will come to later on. Then a hyperplasia is only generation of new myocytes, whereas hypertrophy is increased length and width of the myocyte. So a hypertrophy with a CMR is going to assess the length and width of a segment, of a myocardial segment, of myocytes, and also of the extracellular matrix. So if the myocyte size increases, width and length increases, there is hypertrophy. If there is extracellular matrix also thickens, the myocyte is normal, but extracellular matrix also thickens, even then there is a hypertrophy. Hypertrophy can be either single or both, in both places. So that is hypertrophy. And why are you so much worried about LV hypertrophy? Because LV hypertrophy stimulates collagen pathways and accelerates myocardial fibrosis. The more the thickness, the prolonged the incidence of LV myocardial hypertrophy, so much the fibrosis and so much the damage to the myocardium, so much stiff it becomes, and it might lead to LV failure. So identifying LV hypertrophy, number one, assessing the severity of LV hypertrophy, number two, identify the cause of LV hypertrophy, and prognostication, then treatment response. All of them are the role of imaging. 2D echo is a very good modality, but 2D echo has some limitations, and that is where they ask for CMR. And let us see how exactly we are going to look at LV hypertrophy in the next couple of minutes. So what are the causes of LV hypertrophy? There is volume overload, there is pressure overload, and there is others. Others are infiltrative diseases. So volume overload is because, first we look at pressure overload. Pressure overload is because of systemic hypertension. What is systemic hypertension? There is increased resistance, peripheral resistance of the arterioles, peripheral arterioles. Because of increased peripheral resistance, the LV has to pump at a higher pressure, that is afterload. Higher pressure, LV, that is afterload. Similarly, aortic stenosis, aortic valve stenosis, again there is an afterload. Aortic valve is so narrow that LV has to pressure at a higher pressure. That causes LV hypertrophy. So arterial hypertension and aortic stenosis, both of them are afterload. They produce increased pressure, and increased pressure will lead to hypertrophy. Then volume overload. Volume overload is when there is regurgitation, aortic regurgitation or mitral regurgitation. Whatever the heart has to pump, part of it is going into left atrium, coming back again. So this is volume overload. Because it has to pump more volume, every day more volume. It has to pump more volume, there is increased pressure on the LV, within the lumen of the LV, and there is increased pressure on the wall, so wall hypertrophies. Go back and read Laplace law. Laplace law is very important. All of you go back and read Laplace law. Laplace law tells us about the relation between hypertrophy, wall thickness, radius, LV pressure, and LV wall stress. Laplace law is important. Starling's equation and Laplace law, both are important, but Laplace law is very apt in this particular scenario. I'm not talking about Laplace law. Okay, read about it, Laplace law. It gives you a very good insight upon hypertrophy, what is a compensatory mechanism. Then what are the others? So I've told you, myocyte hypertrophy occurs and hypertrophy extracellular matrix also. Both of them can together or alone. So the others come where there is deposition of substances within the extracellular matrix, not the myocyte. Myocyte is normal there, or myocyte can be dead, or myocyte can be inflamed, but there are deposition of substances in the matrix, and those are amyloid, Danon disease, iron deposition, mucopolysaccharidosis, oxalosis, Friedreich's ataxia. Now, that is deposition in the extracellular matrix. Now, when in both abnormality will take place, is hypertrophic cardiomyopathy, Fabry's disease, athlete's heart, and eosinophilic myocarditis. There is both abnormality of the myocardium and the interstitium or the extracellular matrix. That is these conditions, these 4 conditions. So these are the causes: pressure overload, volume overload, deposition, extracellular matrix, and abnormality of myocyte and interstitium. All of them put together will cause LV hypertrophy. And role of MRI is to know whether there is hypertrophy or not. Number 1. Number 2, what is the cause for hypertrophy? Number 3, severity of hypertrophy. Number 4, prognostication. Is it very bad? How far is the patient going to recover? And what treatment has to be offered? 5, treatment response. After giving treatment, whether hypertrophy has come down and the severity has come down. That is the role of CMR. And all of my predecessors have told you about sequences. All these sequences are useful. I will not touch about T1 T2 mapping. Broadly, we'll go by basic sequences because T1 T2 mapping is slightly on the higher side. But still, let us know what is the role of T1 T2 mapping when it comes into the individual cases. Now, how do you assess LV hypertrophy with MR? There are 4 or 5 parameters. First and most important parameter is LV myocardial mass. LV myocardial mass is assessed to the body surface area. It is known as indexed myocardial mass. Number 2, wall thickness, always measured in end diastole. Always in end diastole. In systole, they can be abnormal thickening. So always measure in end diastole and identify whether it is symmetrical or asymmetrical thickening. Then assess the LV function, because CMR is a comprehensive modality. It has got a role to play in regional and global valve motion abnormality. So assess the valve function, which is going to prognosticate the particular individual. Then tissue characterization. Tissue characterization is by T1 T2 mapping. We'll go into it later on, not in detail, but most importantly is late GAD enhancement or LGE, late GAD enhancement. Now, why it is called late GAD enhancement? I'll just give you about 30 seconds, 1 minute on why it's called late GAD enhancement. Now, look at the normal myocardium. Normal myocardium has got intact cell membranes. The sodium potassium ATPase pump is normal. There is a discrimination between normal myocytes and the extracellular matrix. I told you myocytes and matrix. There's a good discrimination between the myocytes and the matrix. So when you give contrast, the contrast goes into the blood, goes into the myocardium. Myocardium takes, washes out contrast. None of the contrast goes into the extracellular matrix because intact cell membranes. They're intact cell membranes. The myocyte is normal. It is not destroyed. Now, when there is infarction, infiltration, edema, or other conditions where there is inflammation of the myocytes or death of myocytes, the number of myocytes come down. The contrast going in because of destroyed cell membranes will seep into the matrix or extracellular matrix, I told you, into the matrix, and then slowly it seeps from the myocytes into the matrix. It cannot be washed out because from the myocytes, it is washed out, normal myocytes, whereas from the extracellular matrix, it is like a blind end. It cannot be washed out. Because it cannot be washed out, it starts retaining contrast, and that is known as late GAD enhancement. And late GAD enhancement occurs from anywhere between 8 to 15 minutes. And when you do late GAD enhancement, you can differentiate between a normal myocardium and an abnormal myocardium, because normal myocytes wash out contrast, whereas dead tissue, scar, or any inflammation will retain because of loss of normal myocytes and more of extracellular scar formation that retains the contrast, and that is why we call it as late GAD enhancement. So that is an extracellular contrast retaining, that is known as late GAD enhancement. So late GAD enhancement is again a very important feature in CMR to show whether it is a non-ischemic or ischemic cardiomyopathy. What is ischemic cardiomyopathy? Like earlier speaker has told you, Suman ma'am has told you, ischemia and territory, RCA territory, LAD and L6 territories. The typical pattern is known as ischemic territory. Non-ischemic is it does not follow the vascular territory and it shows haphazard random LGE, that is non-ischemic LGE. Now, what is more important is when you call LV hypertrophy, how do you measure LV hypertrophy is very important, and you have to identify what is a pseudo hypertrophy. So many of the times when we do the acquisition, The protocol must be very, very, very stringent. Your tech and you should sit together and tell him that I want the protocol very fixed. I want the angulation. I want a short axis view exactly perpendicular to the septum and in plane with tricuspid and mitral valves, perpendicular to the septum. If any obliquity take place, that goes for a toss. You got partial voluming. All of you know partial voluming. Partial voluming occurs and myocardium appears more thicker than normal. And that is why you have to identify, you have to do proper planning and proper acquisition, and only then your results are valid. Now, this is a very interesting article, very important, and all of you go and download it. 2024 Radiographics, Fundamentals of Cardiac MRI. Very, very good article on fundamentals. Go and read it. It's an excellent article for you to know about the fundamentals. And one most important thing in assessing the LV myocardial thickness, number one, assess in end diastole, not in systole. Number one. Number two, on short axis views. My predecessors have told you, earlier speakers have told you about short axis. On short axis views, in end diastole, draw radial lines like that. Radial lines, take radial. That means maximum thickness you get. In apical and mid, in basal and mid cavity, draw in short axis, whereas at apex, you take in long axis 2-chamber or 4-chamber planes. Because, like I told you, obliquity, when you take it parallel to the valves or perpendicular to the septum, there is slight convexity at the apex where it goes obliquely. That is why you always take 2-chamber or 4-chamber planes to assess the wall thickness in end diastole at apex, and in mid cavity and basal cavity levels, take in short axis planes radial diameter. Number one. Number two, always exclude the papillary muscles and trabeculae in looking at the thickness. Number three, I'll show you the examples. Number three, look at the trabeculae on the RV side. They must be excluded. There's a prominent trabecula known as crista supraventricularis, which divides the RV inflow and outflow. That has to be avoided at any cost because that commonly gives you an error of measuring the LV septum. So if you identify all these structures, measure properly, start measuring like this, follow proper norms, then you will not go wrong. And that is the accurate thickness of what you have to measure. Why I'm stressing all this is it's so important that the 2D code tells you there is wall thickness is 12 millimeters and you claim that it is 16 millimeters. The entire picture changes. So that is why measurement of LV wall thickness is so important. Follow guidelines. Okay. Now, there is one more method laid down by SCMR in a 3-chamber plane. I will not go into it because you can read up in the articles. But in 3-chamber also it is mentioned. But by and large, short axis is the best to measure the LV cavity diameter and the LV wall thickness. So what are the parameters? What are the normal ranges for the wall thickness? Okay. Now, normal wall thickness is less than 11 millimeters at mid-end basal cavity levels. If you go to apex, it will be 3, 4, 5 millimeters. But you are mainly measuring at the mid cavity and basal cavity levels. It is less than 11. You call hypertrophy 11 to 13, mild hypertrophy. Moderate 14 to 15, severe more than 15. The entire story of hypertrophy lies on the amount of thickness, amount of millimeters you're going to measure. That is why it is so important that you measure it properly with accuracy. Measure more number of times, but accurately, like I told you, avoiding all those confounders and false positives. Because, simple example, if the LV hypertrophy is more than 16 millimeters, I would straight away close my eyes and say it is HCM, hypertrophic cardiomyopathy. If it is less than 15 millimeters, I will consider other possibilities of hypertension, aortic stenosis, and athlete's heart and other conditions. So, just by wall thickness itself, you can easily come to an understanding that I am dealing with this condition. If I tell you that wall thickness is 12 millimeters, I would not consider hypertrophic cardiomyopathy. I'll consider something else. By and large, most often also. Similarly, LV mass, when you calculate to body surface area, please note down these measurements. These are standard measurements. Whatever is the asterisk there is an important slide. You can click it if you want. This is an important slide. Wherever there is a asterisk there, wherever there is a star mark there. So this is the LV mass. Calculate to the body surface area and give this because one volume, I will say that LV mass is 170, other says 180. But if you calculate the body surface area, that is more standard. and that is more reproducible. So always calculate the body surface area and give the LV mass. So LV wall thickness, LV mass, two are important for hypertrophy. Then septal lateral wall thickness ratio, that is, again I'll show you the example also. You measure the septum, anterior septum and posterolateral wall or infrolateral wall. That ratio must be usually 1. If it is more than 1, there is abnormality, one abnormality, less than 1, other abnormality. Okay. Now, this is so important for you to know that in my couple of slides, in next couple of slides, I'll show you that without history, you don't stand a chance for diagnosis anywhere. You need history. You need history. You need proper clinical details. You need to note down everything about what 2D is there, how the patient presented, what is the clinical symptoms, what is the ECG, was cath done or not. All of them must be taken before interpreting or approaching a cardiac MR. So important that you cannot report anything in clinical vacuum. Okay. Then protocol selection, measurements I told you, interpretation is so important again, because without, see, if you approach a cardiac MRI, I don't know what I'm looking at. I don't know what to report to. I don't know what to answer to the cardiologist. What answer should I give? What am I reporting there? You have to address the question, address the point to the cardiologist. He wants to know something, give it to him. That is important. Okay. Now, let us go to the case study. Please tell me just 2-3 minutes before my time is over, or 4 minutes before my time is over, because I'm going a lot of, okay. So, again, coming to the hypertrophy, these are the common causes. I do not want you to confuse about Anderson-Fabry, Danon, mitochondrial cytopathy, which probably once in a lifetime case. The common cases are hypertensive heart, hypertrophic cardiomyopathy, amyloidosis, sarcoidosis, athlete's heart. I have not seen a single athlete's heart. I probably India or my part of country does not produce so many athletes. They don't come for cardiac MRI, but I have not seen athlete's heart. And I cannot, probably I can show you from internet, but I don't want you to show you from internet. So these are 5 things which are very important. Hypertensive heart, amyloidosis, hypertrophic cardiomyopathy, aortic stenosis, sarcoidosis. Okay. These are the 4 or 5 things which are very important. And again, remember this point. If you get 100 requisitions for CMR to assess hypertrophic heart, 60 or 65% are hypertrophic cardiomyopathy. So you should know more about hypertrophic cardiomyopathy and okay about other things. Then about 15-20 are sarcoidosis, amyloidosis. Okay. Then hypertensive heart, then aortic stenosis. So HCM, if you know about HCM, you've known most of it. And all of them are kind of, correlated with HCM. Is it HCM or not HCM? 2D comes to you. There is increased apical LV thickness, 11 millimeters. Query apical HCM, CMR. Then basal septum, 12 millimeters. Is it HCM? Query HCM, CMR. So they everything they want to put HCM on one side, and then other side is wall thickness of other. Number 1. Number 2, the other important cause they ask for CMR is there is wall thickness, increased wall thickness. There is diastolic dysfunction. Heart is becoming stiff. Its endostolic volume is less. Heart is becoming stiff. Diastolic dysfunction. And unexplained heart failure. Unexplained wall thickness increase. Now, in these conditions, there are some 2D markers known as cherry on top appearance for amyloidosis, but I'll not go into that. But they think that either there is a hypertrophy or there is infiltrative disorder in the myocardium. So again, one more indication is you have to rule out an infiltrative disorder in the myocardium, like amyloidosis or other condition. Then the third important thing, patient goes to 2D echo for arrhythmias, tachycardia, unexplained heart failure, complete heart block, syncope, palpitation. All these conditions, they find hypertrophy. They want you to know, they want you to identify what is cause for hypertrophy. Because 2D cannot tell you the cause for hypertrophy. MRI, being multiparametric, can tell you the cause for hypertrophy. Can at least lead to the cause for hypertrophy when it has a typical appearance. Number 2, MRI can prognosticate. For example, LGE is more than 15%. That means this HCM patient will have a high complication rate. Then you can give the severity of the disease, again, in HCM and other conditions. So MRI is a multi-modality, the comprehensive approach in hypertrophy. 2D co up to a level is good. After that, they depend upon you to give you the etiology, the prognostication, the severity, and treatment response. That is why CMR is useful in all these conditions. Like I told you, HCM always tops the list. And this is the gist of what happens. What are the conditions? What are the abnormalities CMR has? One is LGE, other is T1 and T2 mapping and ECV. So if you look at here, HCM, it is more than 15 millimeters wall thickness. All are less than 15 millimeters. HCM is more than 15 millimeter wall thickness. Okay. Then HCM is usually asymmetric, rest all are symmetric. Very simple, basic. HCM is mostly asymmetric, rest all are symmetric. Okay. Enhancement. Some have enhancement, some have typical pattern of enhancement, some have atypical pattern of enhancement. So this is the gist of what I'm going to show you the next couple of cases. Okay. For lack of time, I'm not going in detail. Now, these are all 6 examples of hypertrophy. All of them are hypertrophy. All of them are LV hypertrophy. Right? What is what? Probably only one. Number 5, all of you can say it is HCM. Number 5. But rest is very, very difficult. All of them are hypertrophy. What is what? No one knows. But 5Y, I can tell you very confidently, definitely is more than 15 millimeters. By looking at it, and I can tell you that probably that is HCM, and rest all, I don't know what. Okay. Now let us see the first case. There is concentric hypertrophy, agreed or not? Concentric, agreed? Concentric hypertrophy, 13 millimeters. Same again. There is no valves are okay. There is probably mild MR here, mild MR, no TR, right? There is no edema. This is black blood imaging, sterile imaging, no edema. So there is concentric hypertrophy, mild MR, no TR, RV is okay, contraction is okay, right? Now, look at this LGE images. These are late GAD enhancement images. What Suman ma'am has told us in her viability imaging, jet black myocardium and white, pristine white LGE. That is how we differentiate, right? Whereas in this particular case, I don't see a discrimination between endocardial blood and myocardium. Lot of dirty pattern of enhancement. This dirty pattern of enhancement with loss of normal nulling pattern between the endocardium, blood in the endocardium and the myocardium is very typical feature of amyloidosis or infiltrative disorder, right? This particular dirty pattern where normal nulling is not happening. See, if normal nulling occurs and you have proper MRI, you have to have a totally black myocardium and a white LGE. If not, no LGE, okay, but black myocardium. So that discrimination has lost here, and there is abnormal nulling pattern in the myocardium, and almost both are similar, nulling at the same time. Dirty pattern of patchy enhancement within the myocardium, okay, which is typical of amyloid. There is concentric hypertrophy, which is again atypical for HCM. There is no edema. Then, if you look at this T1 map values, which is a clincher, actually, T1 map value is a clincher in amyloidosis, where there is deposition of the amyloid protein, and somehow the amyloid protein will lead to very high T1 map values. If in hypertrophic cardiomyopathy, T1 map values on a 1.5 Tesla are about 1000, normal 960, are about 1000, 1040. In amyloid, they'll go shoot up 1250 to 1300. So, individually, very high T1 map values are very, very strong pointer towards amyloidosis, cardiac amyloidosis. They must be more than 5-6 times the 2 standard deviations. Normally, you take 2 standard deviations, but they're more than 6-7 times the normal standard deviation. Then it is most likely amyloid because there is one condition, native T1 map values are very, very high for in amyloid proteins which they give in a CMR. Now, let us go to the history. We don't know the history before. Now, this is the history. There are all features in clinical history point towards amyloidosis. Known case of amyloid, had amyloidosis, surgery done. So now going back, you can claim and you can say that there is concentric hypertrophy, there's no edema, mild MR, there is enhancement, which is dirty pattern of enhancement, and myocardial nulling is not proper. Both myocardium and blood are nulling on the same time probably. So this is an amyloidosis. I did not want to tell you the history before because history is also very important. This is all very important. But when you identify this particular case, what are the clinchers here? What are the clincher is concentric hypertrophy 1, but it could be seen in many other conditions. The clincher here is abnormal enhancement pattern and abnormal very high T1 map values are very typical of amyloidosis. Okay, so a cardiologist will come only up to this level or this level where there is mitral regurgitation, beyond which LG and T1 mapping they cannot tell you, and this is what MRI is the role to play in giving you the diagnosis, giving differential diagnosis or cause, etiology of the condition. Cardiac amyloidosis, I will not go into detail. I'm going to only show the cases. Let's look at a lot of the cases. Look at one more case. Now, this, I'll give the history straight away. This is a suspected infiltrative cardiomyopathy, amyloidosis. There is biventricular enlargement, biatrial enlargement, biventricular dysfunction, multiple clots. Recent PET-CT negative for amyloidosis. That is negative for transthyretin amyloidosis. It's okay. And whole body PET negative for metastasis or any tumor related issues. So look at this short axis. There is, all agree that there is concentric hypertrophy. Agree, concentric hypertrophy. There is 4-chamber concentric hypertrophy, biatrial enlargement. There are clots. Look at the clot in the right atrium, clot in the left atrium. There is aortic regurgitation, moderate, right? Now, if you look at this enhancement pattern here, you can see that there is diffuse subendocardial. All of you agree? All of you agree here? Diffuse subendocardial enhancement. Diffuse all over subendocardial enhancement. Just remember this slide. Take a picture. This particular image, very typical of amyloidosis. There is diffuse subendocardial enhancement all over the myocardium in a given setting of biatrial dilatation, biventricular dysfunction, cardiac thrombi, okay, concentric hypertrophy. All of them are very typical of cardiac amyloidosis because 84 to 90% of times cardiac amyloidosis can produce this diffuse subendocardial or tram line type of LGE, late guard enhancement. Very typical of amyloidosis. Okay, now let's go into the second case. Again, concentric hypertrophy. Let us see this concentric hypertrophy. LV wall, industrial wall thickness is 11.6 millimeters. Look at the 3-chamber plane. There is mild MR. There is no LVOT obstruction. Concentric hypertrophy. But if you look at the aortic valve here, look at the aortic valve. Look at the jet, the dephasing jet that is going into the ascending aorta from the aortic valve. Look at that jet. That jet will tell you that there is aortic stenosis. There is no edema here on stair images. There is no LGE at all. This is short axis, 4-chamber, no LGE. There is some kind of faint, very faint mid-mural, mid-myocardial LGE, but not significant. T1 map values will not go into T1 map values. Look at the aortic valve, severe calcific aortic stenosis, right? Severe calcific aortic stenosis. So this patient is a 70-year-old female, severe degenerative aortic valve disease, normal systolic function, grade 2 diastolic dysfunction, concentric LVH, pre-TAVI assessment. We want to do a CMR. And if you go back to the CMR, you can see that there is concentric hypertrophy. There is concentric hypertrophy here. And aortic valve, there is a dephasing jet, very significant dephasing jet going along the aortic valve. You can also take a aortic valve in first view and measure the planimetry you can do. But you can also, you are seeing the jet here. We already know there is aortic stenosis. So aortic stenosis is one condition again can produce concentric hypertrophy. And in your history in 2D co, if they ask you that I am seeing concentric hypertrophy, what is the cause? Go and look at the valves. In aortic valve area, there must be at least moderate to severe aortic stenosis. Then you are a diagnostic criteria is filling up that there is concentric hypertrophy, aortic stenosis. So aortic stenosis is most likely because of LV hypertrophy is most likely because of concentric hypertrophy of aortic stenosis. And then what is the role of CMR? Role of CMR is if there is abnormal T1 map values, that means there is interstitial fibrosis and they fare badly, they have poor prognosis. If there is LGA, significant LGA in the LV myocardium, then again poor prognosis in aortic stenosis. So that is aortic stenosis. We'll not go into the detail. Then look at this. This again, there is concentric hypertrophy. Again, this concentric hypertrophy here. Fourth chamber, short axis. There's no mitral regurgitation. There's no LVOT obstruction. No LG. There is concentric hypertrophy. And this is hypertensive heart. Known hypertensive heart. That's hypertensive heart. So concentric hypertrophy, three conditions we have seen: aortic stenosis, amyloidosis, hypertensive heart. Three conditions, out of which MRI has a very major role to play in amyloidosis, in aortic stenosis and hypertensive heart. Not great role to play because usually not many findings on CMR. If you have to extrapolate, you'll have findings on CMR. Now, let us see this particular case. This is you can see here, there is asymmetric hypertrophy. There is asymmetric hypertrophy in the anterior septal wall. There is little thinning of the myocardium here in the inferior wall and lateral wall. Asymmetric hypertrophy there. You can see there is wall motion abnormality, global hypokinesia, wall motion abnormality. No edema. When you come to LGE, there are all patterns of enhancement here, all patterns of enhancement. There is subepicardial, midmural, and RV septum side of enhancement. Subepicardial, midmural, and RV septum type of enhancement. RV septum or RV side of septum enhancement. And this particular pattern of enhancement in presence of asymmetric wall thickening, global hypokinesia, and areas of thinning and thickening is very suggestive of cardiac sarcoidosis. Remember that this particular presentation of asymmetric thickening, areas of thinning, enhancement of typically subepicardium to midmural and RV side of septum enhancement are very typical of cardiac sarcoidosis. And this is the clinical history of this case. No risk factor, CEG normal, severe dysfunction, 2D echo, global hypokinesia. That's a cardiac sarcoidosis. This is a case of cardiac sarcoidosis. So now, cardiac sarcoidosis, MRI is not the primary modality in acute setting. In acute setting, all of you should remember, it is the FDG PET. FDG PET is most important in active phase. Cardiac MRI will come only in the next post-inflammatory or chronic phase. Always remember that if someone asks you, I'm suspecting cardiac sarcoidosis acute phase, send them to PET, not to CMR. Only in subacute and chronic phases, CMR has a role to play. That is very important, but you should remember. Now comes the main thing of hypertrophic cardiomyopathy. So when your doctor has referred to you by saying HCM, you take the history of family history also is very important. You always ask the patient, even doctor will also tell you that there is a family history of HCM or family history of sudden cardiac death. Sudden cardiac death in a family history will also is a clincher towards HCM. So cardiologist will tell you that there is HCM because that's also a very simple stamping diagnosis for him. So he'll send you HCM to prognosticate, to look at scar quantification, to look at wall thickness, to look at other things like SAM or systolic anterior motion of the mitral valve, or to look at LVOT obstruction, how much LVOT obstruction, to look at the function. Similarly, to look at the apical cardiomyopathy, apical HCM. Apex is not a very easy thing for 2D echo to be identified. So apical HCM, again, MRI has a role to play. So HCM, these are two siblings, genetics, identify. Typical LGE also. What is a typical LGE? What is typical LGE in HCM? Number one, look at this LGE, RV insertion point. There is bright enhancement in the RV insertion point. This is a very typical RV insertion points, anterior inferior, is very typical of HCM. And also another pattern is diffuse faint mid-myocardial enhancement. Diffuse faint mid-myocardial enhancement. That also, these two patterns are very important. One is a frank bright LGE at the RV insertion points and mid-myocardium, and also a pattern of faint mid-mural LGE. It's a hazy pattern, hazy LGE. These two are very typical of HCM. And we have quantified the scar burden or fibrosis by saying that 14% in the one of the siblings and 20% in the other sibling. So what is 14? What is 22? Any scar fibrosis more than 15%, those are high risk for sudden cardiac death and arrhythmias in HCM. So role of MRI, severity and prognostication. So one sibling has 14%, it's okay. 20%, this patient stands a high chance of SCD and arrhythmias, so they have to go for ICD placement. So these are all, MRI has a very major role to play in HCM. What are diagnostic criteria? What are diagnostic criteria for HCM? Increased wall thickness in at least one myocardial segment or more than 15 millimeters. Okay, but 13-40 millimeters can also be seen when there is a family member has HCM. Even 13-14 millimeters also can be taken into consideration to diagnose HCM. Okay, then septal to inferior lateral valve ratio more than 1.8 to 1.5 is important for diagnosis of HCM. This is what I told you. I show you the measurement. Measure the anteroseptal wall here. Exclude the trabeculae. This is the crista supraventricularis. Exclude crista supraventricularis. Always very important. Look at the measurement here. Look at the measurement here. Infralateral wall, anteroseptal wall. Measure, give the ratio, which is more than 1.2 to 1.5 in HCM. No other condition can produce. Probably Danons can produce and some other, but by and large, about more than 80-90% times, an asymmetric HCM, asymmetric septal hypertrophy, which is almost 60 to 70% of cases of HCM, can show this particular pattern. Now, again, this slide is important. What is rule of 15 in HCM? Rule of 15 in HCM. Number 1, wall thickness must be more than 50 meters in diastole, in end diastole. Septal to infralateral wall thickness more than 1.5 HCM. Presence of LGE more than 15% severity of HCM. They go for SCD. LV wall thickness more than 30 mm, multiples of 15, 30 mm, poor prognosis. Then LV outflow gradient, aortic wall gradient. Normally, if it is more than 30, it is important, but more than 60, it is severe gradient. So rule of 15 is 15 and multiples. 15, 15, 15, 30, 30 and 60 again. Defined as a gradient more than 30 is definitely abnormal. More than 60 is very severe and they need some treatment. That is rule of 15. Now look at these are all phenotypes of HCM. All phenotypes of HCM. This is a typical basal HCM, asymmetric basal septal hypertrophy. Now this is a reverse curvature because the basal septum is spared here. Basal septum is spared. The mid septum is more involved. And this particular reverse septum HCM is known to be associated with sudden cardiac death. Okay, this is a mid cavity HCM with apical ballooning, apical aneurysm. Again, in this apical aneurysm, if there is LGE, that means scarring. Those are the patients who go for sudden cardiac death and they need immediate treatment. Mid cavity with apical ballooning. This is a global or diffuse HCM. Overall, I mean all myocardial segments are involved. This is the apical HCM. Look at the septum here, normal wall thickness. Look at the apex, significant increased wall thickness. That is apical HCM. And this is a HCM, basal HCM with LVOTO, which you can also see in the 4-chamber plane. But you can always see this better in the 3-chamber plane or LV inflow outflow, where that is the basal HCM. Look at the systolic anterior motion of mitral leaflet. This is the HCM, basal HCM. There is LVOTO. How do you say it? There is LVOTO. There is dephasing artifact, dephasing flow artifact occurring at the level of LVOT below the aortic valve. If it is aortic stenosis, the dephasing artifact occurs in the ascending aorta, whereas in LVOT obstruction, dephasing artifacts occur at LVOT or below the aortic valve, and that is LVOTO. This is the case. There is no LVOTO, and this is an apical HCM where more of apical thickening and less of basal thickening. Okay, so I think I have done. Will not go on. For those who are seniors there, the two patterns of LV myocardial enhancement. This pattern is replacement fibrosis. This pattern is interstitial fibrosis, right? For all the seniors there. Now, this replacement fibrosis will have very high ECV values. ECV correlates with almost a fluid content, will have very high EC values. And this hazy enhancement has high native T1 map values. Native T1 map values give a composite T1 relaxation time of intra and extracellular component. ECV will give you predominantly extracellular component. So a very high EC value occurs in replacement fibrosis. A high native T1 map value will occur in both interstitial fibrosis, predominantly because of interstitial fibrosis. So these particular cases will have very high T1 native T1 map values. This is because of replacement fibrosis. This is because of interstitial fibrosis. Two types of enhancement in HCM, right? Let us not go into details. I think I'll close it at this level. I'll not confuse you anymore. Now, what are the advantages of CMR? Are everything you can see over 2D echo, accurate limitation of endocardium, obtaining infinite margin planes, both ventricles, better estimation of ventricular volume function, hypertrophy compared to 2D echo is better estimation of the wall thickness, focal forms can be better assessed, and quantification of fibrosis can be done better on the HCM. Now, this is the case they presented. They told us that they suspected biventricular HCM, but you can see asymmetric thickening of LV apex and severe loss of LV apical endocardial cavity, also of the RV apical endocardial cavity. And this is a very typical pattern of chronic endomyocardial fibrosis. It can come as a differential diagnosis. Okay, that's it then. We'll not go into all those conditions which you don't see regularly. We'll not go into it. Let me come to the recap. Role of CMR in hypertrophy. Accurate assessment of mass and wall thickness. For all who are starting to do CMR, remember guidelines, endospheric wall thickness, measure in short axis plane, in apex, measure in the 2-chamber or 4-chamber plane. Okay. Patterns, symmetric, asymmetric, right? Myocardial function, global, regional, diastolic function. Myocardial tissue characterization by T1 T mapping or LG. LG also is very important. Identify the scar. You say whether it is a non-ischemic or ischemic cardiomyopathy. Okay. Then differentiating etiology of LVH, I told you all 4 important points: amyloidosis, hypertension, aortic stenosis, sarcoidosis, asymmetric HCM or hypertrophic cardiomyopathy. Risk stratification and guiding therapy, monitoring disease progression and treatment response. These are the guidelines you have to go and check. Thank you very much for your attention. Thank you, Ritu.
Thank you so much, sir, for such an insightful presentation. Any questions from the attendees? So we have.
Yeah, please, I'll take the question, please. Yeah, please take it. Can you please? Yes, that's a good question, but unfortunately, LVOTO quantification is not very accurate on CMR. It is more done by 2D echo because there's so much of dephasing artifact. It is very tough, and the guidelines say that. Can you just move a set? Yeah, guidelines say that even if you do, it is not as accurate as 2D echo. So 2D echo is the modality of choice for LVOT obstruction quantification.
Between the septal wall and the septum. So if it's less than 10 mm, it is like more severe.
Yes.
That is something. Otherwise, as you said, it is very difficult. We rely on echo only to look at the gradient.
Because they have tried. Many people have tried and they have quantified. By 2D flow studies and other things they have quantified. Right. But 2D echo gives a much better quantification and assessment of severity of LVOT. Pre-or comments also.
Yeah. Mainly CMR is for prognostication only. Yeah.
Because we tend to do, but we fall short. We don't have full accuracy. So we don't even go into it. You identify with visual, mild, moderate, severe, and then like she said, the 10 millimeters rule, and then that's it. Priya, want to add any point? Anyone? Ritu want to add a point? Suman ma'am, want to add any point? That is okay.
It was an
Excellent presentation, sir. And you explained all the fundamentals so simply and so beautifully. It was superb talk. Very nice.
I now invite Dr. Ritu Agarwal, ma'am, for her next presentation on updates on MRI contrast guidelines.
I would just want thank you, Nori sir, for that talk. I mean, it was really great. And it was so lucid and everything flow on so well. I mean, you really took that pain to make us all understand that. Thank you so much, sir. Okay, so now I'll be talking on MR contrast guidelines and update. And this is actually a very important topic because we get a lot of questions from the clinicians as well as the co-radiologists on when to give contrast and when not to give contrast, or what actually matters and what do not matters. And every one of us, this is for MRI. It's not just for cardiac MRI, it is for MRI in general. And all of us must know that because our clinicians actually look forward to us on answering these questions. So first we talk on the risk factors for adverse reactions to IV contrast. So the adverse allergic reactions to modern GAD-based contrast media, that is GBCA, are uncommon. And there is no cross reactivity of different classes of contrast. For example, if a patient has a prior reaction to GBCA, it doesn't mean that he will have a reaction to CT contrast, the iodinated contrast, or vice versa. Then fasting. Now, this is a very traditional norm that has been set up कि 2 घंटे की fasting चाहिए. And I've never understood the logic behind this. So currently we use the GBCA, which is much slower risk of vomiting. And pre-procedural fasting actually have some negative effects because you have to schedule the limitation. The patient is in the scanner is vacant. You can take the patient, but you have to wait because उसने खाना खाया. So that is something which creates problem. So there is actually no need to wait for the patient unless and until it's a very heavy meal or something. Then it also creates hypoglycemic risk if the patient is diabetic. And then it is in general uncomfortable for the patient to be roaming around in the hospital in a fasting status. The hospital itself is a stressful thing for the patient. And then you ask him not to eat, that becomes more stressful. Then in 2019, a study of more than 1.5 lakhs patients of injection of GBCM demonstrated that there was only 0.03% in mild percentage of mild adverse events, which included nausea, vomiting, and mild rash. So there is no actual preventive effect of fasting on risks of nausea, vomiting, and aspiration. And it is not recommended only if the patient needs sedation. If the patient has to undergo anesthesia, then yes, you have to make the patient fast. Otherwise, we do not. Now, extravasation of GAD contrast is actually much less common. It is 1/6 of what we see in a CT contrast. And the difference is because we inject GAD in such a small amount as compared to the CT contrast. It's just 10 to 15 ml of gadolinium versus a 70 to 80 ml in a normal iodinated contrast. And even on a CC to CC basis, the GBCAs have much less toxicity as compared to the iodinated contrast. So therefore, these reactions are mostly managed conservatively with some arm elevation and cold compress if they happen. And most of the times, they do not cause any issues. You need to reassure the patient, but then metformin. Now, metformin has some problems with CT contrast. However, it is not necessary to discontinue prior to injection of GAD. And because the amount of, when we are using the GAD in the recommended doses, which is 0.1 to 0.3 millimole per kilogram body weight. So the patient can continue on metformin therapy. Now in children, there is always confusion what to do and what not to do. The simple sentence is there are no specific guidelines as per as injection of gadolinium-based contrast goes, and they follow the same adult guidelines. There is no evidence of pediatric renal toxicity, and all these guidelines are per the latest ACR manual. There is no evidence of pediatric renal toxicity from GBCA at the approved doses. Extravasation, again, is of minimal clinical significance because of we inject even smaller volumes because the dose is calculated per kg body weight. So small children means lesser GAD, lesser volume of contrast. And there is no evidence-based guideline to prevent NSF in children in particular. And we will deal with NSF in the later slides. So we have to essentially follow the adult guidelines for identifying at-risk patient. in the presence of impaired renal function. And as a general rule, it should be avoided, GAD-based contrast should be avoided in the setting of acute renal injury and chronic renal injury. This also has some caveat, which we'll be talking subsequently. Now, adverse reactions on clinical doses, which is 0.1 to 0.2 millimole per kg for most GBCA, is 0.07 to 2.4%. And most reactions are physiological, include feeling of some cold, some warm, some pain, some nausea with vomiting, headache, some paresthesia and dizziness. And these are mostly managed conservatively and go back on their own. The allergic reactions are uncommon and they actually vary in frequency 0.004% to 0.7%, which is very less. Now, pregnancy again is a very confusing topic for most of you. So I want the residents at least and the newer consultants to please listen to all these very carefully. GBCA pass the fetal barrier into the fetal circulation. And ACR manual recommend therefore avoiding the routine administration of GBC to a pregnant patient. So when a pregnant patient needs a MR, we usually avoid it in the first trimester. And if we do a non-contrast MR, and all this is after an informed consent. However, if the patient needs GBCA for some diagnosis that has a significant impact on the patient management, when there is significant clinical benefit outweighs the risks of unknown risks to fetal exposure. So please note the risk is unknown. We do not know whether GAD cause any problem or not. It is that we do not know that it cause a problem and we do not want to take that chance. But if the patient benefits from contrast injection, then yes, you do a contrast, but after an informed consent from the patient and a proper discussion between the provider and the patient. And we should use one of those agents, which is group 2 agents, to be at the lowest risk of developing NSF in the lowest possible dose. And if the patient has severely impaired renal function, then the same guidelines we follow as in a non-pregnant patient. Now, the patient who are breastfeeding, another very sensitive issue. So GAD is excreted in breast milk and therefore the change, a slightly change in the taste of the breast milk happens. Now, out of the dose which we inject, it's only 0.04% that is excreted in the breast milk. Out of the contrast that goes to the infant, only 1% is injected, is absorbed by the GI. So essentially, the amount that reaches the infant is 0.0004% of the dose that you gave. So out of that 10-15 ml you gave, only this fraction goes. And this is actually far less than the permissible dose if the infant would have a contrast study. So therefore, the risks from the GAD, which is being absorbed by the breast milk, is actually remote. And therefore, it is safe for the mother and the infant to continue breastfeeding after receiving a GBCA. However, this decision should be left on the mother. We should give all this information. And if she still is not comfortable, she can pump and she can stop breastfeed for a while if she wants to. The only problem, usually the infant stop taking the feed because there is some change in the taste of the breast milk. Otherwise, it is not harmful as such. Now, the important topic, NSF. So NSF is primarily a disease which involves the skin and the subcutaneous tissues. It can also involve the lung, esophagus, heart, and the skeletal muscles. Mostly there is some thickening and some pruritus, some itching. Sometimes the patient develops contractures and joint immobility. In some patients, it has been reported to be fatal. Now, the concept of NSF came from some early reports which were done with group 1 agents. So yes, we do accept that some GBCA is associated with NSF, but which one is the most important one? And most of them were gadodiamide, gadopentate, diamiglutamine, and gadoversetamide. However, these were mostly the group 1 agents, and there have been few, if any, unconfounded cases of NSF with the newer agent. Now, the problem is the people of nephro, they do not read the latest guidelines. And there is some sort of block about patients with renal failure, no GAD. It is then your role as a radiologist to step up to present them with these data and to educate them that a patient should not be denied a contrast examination just out of fear. It has to be on the basis of some conclusive data of what actually happens and what doesn't. So in a patient who has a chronic NSAID CKD when the GFR is less than 15 and severe CKD when the GFR is less than 30 but more than 15, is 1 to 7% chance of developing NSF after exposure to group 1 agent. However, if the GFR is more than 30, then there has been rare published cases of NSF. So if the GFR is more than 30, you can give anything you want, whatever comes. If the patient is acute kidney injury, then 12 to 20% of the confirmed cases of NSF occurs in patient with acute kidney injury superimposed on CKD. However, some NSF comes in AKI without CKD. So AKI itself is a risk factor for NSF with or without CKD. Now, based on the most recent evidence of ACR, Committee on Drug and Contrast Media, the risk of NSF in patients who have exposed to standard or lower than standard doses of group 2 agents is sufficiently low and non-existent so that assessment of renal function is optional prior to IV contrast. So what does this mean? This means if you are using one of the group 2 agents, then you do not need to do a routine GFR or a serum creat for those patients, which actually saves a lot of time. In my practice, I have stopped. I actually went personally to each and every cardiologist and CT radiologist surgeon. Ki, sir, if you are advising a cardiac MR, please don't write a serum creat. Because what happens, patient 8 बजे आता है, serum creat करवाता है, 1 बजे उसका number आता है, 1 बजे the scanner is so filled up that it's hard to accommodate that patient in the scanner. And if the patient doesn't go for a GFR, he comes at 8 o'clock and gets a scan done. So if we are using a group 2 agent in a practice, and if you are using a group 2 agent, then you do not need a GFR. However, if you're using a group 1 agent, then you have to do a GFR because then you have to decide if the GFR is more than 30, then you can safely use. And if it is less than 30, then yes, you cannot use group 1, then you have to give a group 2. Now, what is the difference? Difference is just cost. It's 1,000 rupees. That is it. Now, in all instances, the group 2 agent should be administered if they are deemed necessary and at the lowest dose. That is always there, that you give contrast when required, but you do not stop giving from a contrast when it is required. Both of these conditions hold true. And we should be using the minimum dose, but we should not minimize the dose to reduce the diagnostic quality. Because then even if you're giving that 5 ml, that 5 ml is waste essentially. So when you give the adequate amount to give you a diagnosis, do not overdo it, but do not underdo it as well. Now, multiple doses, if the patient is not at risk of NSF, that means when the renal function is normal, there is no contraindication. And even at the risk of NSF, if you use a group 2 agent, then it is okay. So if the patient needs multiple, like he had a scan in the morning for suppose a brain MR, and then he comes back with a abdomen or a cardiac MR for some other indications, you can do it in the same day, but you should use a group 2 agent. The patient who was on NSAID renal disease and dialysis, then in these patients, group 1 is contraindicated. You should not use them and use a group 2 agent. Now, if the patient is receiving dialysis, it is recommended that the patient, the MR, the contrast exam is done before the scheduled dialysis so that after the dialysis, the contrast wash off. However, this is a bit confusing. However, the dialysis should not be altered or not be changed because of injection of contrast. So what does this mean? If you know the patient has a dialysis schedule tomorrow, and if possible, you do a contrast exam today so that the patient gets his dialysis tomorrow. But suppose if the patient had his dialysis today and the next schedule is on next week, you do not delay MR, you do the MR, and you do not ask the patient to get the dialysis. He goes on his routine schedule. You try and get it done before the dialysis, but if it doesn't fit, you do not bother. But you use a group 2 agent. That is the most important thing. You use a group 2 agent. Now, the patient who is CKD 4 and 5 and the GFR is less than 30 and not on dialysis, you do not use a group 1 agent. We should always use a group 2. In the patient who has GFR more than 30 but less than 60, NSF is exceedingly rare and we do not need to observe any special precautions, which means you can use group 1 or 2 or 3, whatever you want. If the patient is CKD 1 or 2, when the GFR is more than 30 to less than 120, there is no evidence that there is any risk of developing NSF and you can use any GBCA. So essentially in these both two groups, less than 30, you need to worry. With group 1, more than 30, you can do whatever you want. But in the lowest dose and if indicated, whatever I want means we cannot be reckless. And then in a patient with acute kidney injury, we should avoid group 1 agent. And if we GBCAs are required, then we should use a group 2. So acute kidney injury group 2, GFR less than 30 group 2, otherwise you can use any of the agents. Now, these are the agents with greatest number of NSF cases, the group 1, which include gadodiamide. It comes with Omniscan, gadopentate, which is Magnavist, and gadoversit, which is Gubert. And the patients for which group 3 is the data is limited. And there have been few cases which we do not know for sure. And out of this is only one EOVist. Now, this is the one I need you to look carefully at, because these are the ones with very few of any unconfounded cases of NSF. And out of these are Gadavist, Baltihans, Dotarim, Prohans, and Illusory. And we are using gadobitrol in our practice, but you might use whatever comes with. Now, the GAD agents can also be divided on the base of the ligand. It can be a linear molecule or a cyclic molecule. So in a linear molecule, they have a linear elongated structure, a ligand, which wraps around the GAD ion. And a macrocyclic, it is more a cage-like structure with the ion in the center of the cavity. And both cyclic and linear compounds can be ionic and non-ionic. Now, out of these, the green ones are the ones group 2 agents, and the yellows are the group 3, and the red are the most one associated with NSF. So you can see both the 1 and 2 can be ionic as well as non-ionic. So that is a separate story and need not to be confusing. So with respect to NSF, GBCA is relatively safe. Group 2 GBCA is relatively safe. And there was a study, gadobitrol and renal impaired patients. This is a prospective, international, multi-center, open-label study in which we used gadobitrol enhanced MR. And there was no NSF reported in the 2-year follow-up period. So out of 284 of 908 patients, which means 31%, who had a GFR less than 30, there were no cases of NSF reported. And there was another meta-analysis in which they analyzed 16 studies of about 5,000 patients with stage 4 and 5 CKD who were given group 2 agents and monitored up to 72 months. So there was no NSF reported. So therefore, to conclude, gadolinium enhanced the value of MR. And when I talk of cardiac MR, I always discourage them to do a non-contrast cardiac MR. Essentially, I feel a non-contrast MR is essentially like a better echo. It doesn't give you a lot except the flows. So we should use GAD whenever required. NSF is a problem in a small subset of patients with advanced CKD, but most of these are related to group 1. GAD is mostly cleared from the body, and this is the important thing, that trace amount accumulates in the tissues, in the brain, sometimes even in patients with normal renal function. But the most important thing is we do not know what happens with this accumulation, and we do not know, we have no documented adverse effect if for these agents, for these secondary to these accumulation. And in patients with high risk patients, such as the patients with advanced CKD, we should balance the risks against the denying a clinically well-indicated contrast exam. So if the patient, the bottom line is, if the patient needs contrast, you give him a contrast, but you give him a group 2 agent just to be on a safer side. Thank you so much.
Thank you so much, ma'am, for such an informative talk. Any questions from the attendees? So I now request. Thank you, ma'am. I now request our chairpersons for any closing remarks on ma'am's session. To felicitate our esteemed chairpersons, I now invite Dr. Mahipal Singh sir on stage. I request Dr. Meenu Bagratta ma'am to come forward, and Dr. Kirti Rana Chaturvedi ma'am. And Dr. Priya Chudgar ma'am. Thank you so much, sir. Thank you, ma'am. We now dismiss for a short tea break and reassemble after 15 minutes to resume our further sessions.
हाँ, वीडियो आए वीडियो हाँ वीडियो ऑटो मोड लैपटॉप मेरा चलेगा क्या मेरा मैकबुक है क्योंकि इसमें मैकबुक चल जाएगा ना क्योंकि ये देखो ये वीडियो रन नहीं हो रही है सारे वीडियो है मेरा मैकबुक दिखा देते हैं
चलो
Welcome again. Let us proceed with our further sessions on cardiac MR. And to chair the sessions, I invite Dr. Sunita Purohit, ma'am, Head of the Department of Radiology at Santokh Bahadurji Memorial Hospital, Jaipur. And Dr. Ritu, ma'am, Associate Director, Cardiac Imaging at Eternal Hospital, Jaipur, to kindly come up on stage and take their seats on the dais. Thank you so much, ma'am. I now invite Dr. Priya Chudgar, ma'am, for the presentation on cardiac MR and cardiac masses. Ma'am is currently working as cardiovascular radiologist at Jupiter Hospital, Mumbai. She is also General Secretary of Indian Association of Cardiac Imaging and Faculty of Certificate Course in Cardiac MR and CT at IMM AST, Mumbai.
Thank you, organizers, for conducting such wonderful CME and giving me this opportunity. Just two things before I start my talk for all the newcomers. Now, probably when you venture into your clinical practice in radiology, I mean, as we are all aware that how neuroradiology has evolved, musculoskeletal radiology has evolved, and it is really established. I mean, the role is done that, neuro, musculoskeletal role of imaging is established. But same thing is the next era is of cardiac CT and MR. And it is so much, there is so much of growth in this specialty. And in case if anyone is, interested into doing this, maybe you may find that these lectures, probably you will feel that how much take home message you can take it. But you really have to develop the interest in this subspecialty, because not too much of basics about cardiac anatomy, physiology are taught during our radiology training. So it is important that you have to master these skills so that you standardize your scans and create awareness among cardiology population as well. There is a lot exciting thing in cardiac CT and MR. Currently, like with myself and Dr. Nuria, we are part of Indian Association of Cardiac Imaging, where there are like-minded cardiac imagers across the country. We have our training workshops. There are educational contents on the websites. Online meetings are happening. Be part of the community, because no textbooks are also enough, because everything keeps on evolving. So there are SCMR, ISCI, a lot of other contents are also there. But in case if anyone wants to pursue this, there is a lot of excitement and lot of new things which is happening. Yeah. Okay, so my talk is about CMR in cardiac masses. I will try to cover approach to cardiac mass with protocol and few common interesting cases. Now, when it comes to cardiac mass, cardiac MR is an advantage because it gives an integrated anatomic functional approach, as well as it can characterize the cardiac mass. Because anatomic and functional imaging characteristics probably can be seen on the 2D echocardiography. But tissue characterization, vascularity, probably that is a strength where cardiac MR can add value. And also for the extra cardiac assessment. What is it doing to pulmonary veins? What is it doing to surrounding mediastinal structures? All those information is provided on cardiac MR. So how do you approach a cardiac mass? First thing, location and anatomic relationship to the adjoining cardiac chambers. You can evaluate the mass, whether it is smooth, irregular, or infiltrating. Whether the mass is mobile or not mobile, because sometimes it is prolapsing across the valve, then you will know that it will be causing functional significance. Morphology of the mass, whether the signal intensity adjoining to the myocardium, how is the mass looking like? Whether it is vascular, what is the enhancement pattern? Are there any other complications like pericardial effusion, or is there any extra cardiac spread? So all these are the points in a checklist probably you should approach when you approach a cardiac mass. And you should also tailor your examination also accordingly, because anatomical black blood stack will actually tell you anatomic information, while the cine images will tell you about the functional characteristics. Late gadolinium enhancement and perfusion, mainly for the vascularity and LG images. And sometimes to rule out thrombus, you require a higher TI image that we will see now. So basically CMR protocol, all this what we have seen, Dr. Ritu has covered, whatever we have covered so far, the protocol has to be tailored for a cardiac exam, Because in case if the mass is sitting in the right atrium, your protocol will be a bit different because everything has to pass through that lesion. Similarly, in case if there is a doubt that it is a thrombus, you should also add this late gadolinium enhancement with high inversion value, because on this also the thrombus will always remain dark. You can add T1 and T2 fat suppression because maybe in case if there is a suspicion of a lipoma, then probably this would give us a clue. So all these images, tailoring depending on where is the mass located, adding your parametric imaging in case if you have this, all this probably will give you an approach how you should approach a mass. So whenever there is a suspected cardiac mass, either on a 2D echocardiography or on clinical examination, detailed history is important. And you want, first thing what you want to rule out is that it is not a normal variant or pseudotumors, because they also often mimic heart. It is not uncommon that 2D echocardiography will report something like a mass, but it could be just a fat in the interatrial septum. So all those things you should be aware. Also, sometimes a thrombus, which can be seated in anywhere. It could be in the left atrium. It could be seated in the along the wall in the mural thrombus in the LV cavity. Thrombus also should be ruled out. And after ruling this out, you know that it could be a neoplasm. So let us look at some few common pseudotumors which can mimic heart, which can mimic a cardiac mass. For example, abnormal non-cardiac structures. Like in this case, a large hiatal hernia, sometimes a pericardial cyst, probably which would be seen very well on the CT scan as well, can mimic a mass. There are some normal variants. For example, this crista terminalis in the right atrium, eustachian valve, which is just near the opening of the inferior vena cava, they also can mimic a cardiac mass. So all these are normal variants. Sometimes non-neoplastic structures. What you see over here is the mitral valve, and near the annulus, sometimes you can have a mitral annular calcification, which can mimic a mass. So it is a non-neoplastic lesion and which could mimic a mass. So all these things, variants, anomalies, you should definitely be aware. So these are few examples. What you see over here is a crista terminalis. Here is the eustachian valve. What you see over here is in the where the IVC is entering right atrium. Sometimes trabeculated pectinate muscle in the cardiac mass, but you can see that how it is mobile, and this is what probably which could have mimicked mass, or a lipomatous hypertrophy of interatrial septum. And you see over here, it is fat signal intensity. You can see that it is similar to subcutaneous fat, and it is sparing fossa ovalis. So this classical dumbbell-shaped lesion, you know that it is a lipomatous hypertrophy and not a mass. For a thrombus, as we have seen earlier, it is important that you rule out a thrombus with high TI values. So after your routine LGE images with normal TI values, you should repeat another set, probably on a 600 for a 1.5 or around 850 on a 3 Tesla scanner. Why? Because a small thrombus, as you see over in left atrial appendage, or some mural thrombus in the left atrium, sometimes a thrombus could mimic a mass in the LV cavity, or which could be so much in a large aneurysm. So all these thrombi, whether you are not sure whether it is actually a thrombus or it is just adherent to wall, when you repeat another set with TI value like so much higher value, it will still remain dark. Then you can confirm that it is a thrombus and nothing else. So in case whenever there is a suspected cardiac mass and you have ruled out all the normal variant pseudotumors and thrombus, then finally you come to neoplasms. Now neoplasms, as in all the other systems, it could be either primary or secondary. Primary again could be benign and malignant. Let us see few cases, few common neoplasms. So atrial myxoma, which is the most common primary cardiac neoplasms and which comprises that 50% of the primary cardiac neoplasms are myxomas. So myxomas are usually pedunculated, sessile, mobile lesion. They have a pedunculated stalk, what you see over here. Atrium, left atrium is the most common site. So whenever you see a left atrium pedunculated lesion, which is attached to interatrial septum, mobile, signal intensity as compared to adjoining myocardium, it will be slightly higher. It can have variable enhancement. It can show calcification. It can show prolapse into the valve. All these structures, probably you know that it is a myxoma. Another common tumor, second common tumor is a papillary fibroelastoma. Papillary fibroelastoma are most commonly situated on the aortic valve, as you see over here. So they are very tiny on the aortic side of the aortic valve. It is a small pedunculated 5 to 8 millimeter. Sometimes it may not be, you do not have appreciate so much on MR, but on echo it is seen very well, because on the valve to appreciate those 8 to 10 millimeter images. And you can imagine that, to capture this, if there is a suspicion, it is so important to take those thin sections along the valves, to take that vascular images. Perfusion image should pass through that lesion, and as well the LGE should pass through this. And as you see over here, this would show intense enhancement. Typically, these patients can have complications like stroke or acute MI or ventricular arrhythmia. So that is another common tumor. One of the common differential for this would be a vegetation. So now, for example, in case if you want to differentiate myxoma with thrombus, which is a very common condition, whether it is a myxoma or a thrombus. Myxoma would be always slightly hyper intense to the adjoining myocardium, while thrombus will be iso-intense. But the main thing, the clue would be the late gadolinium enhancement. Myxoma will show some enhancement, while LGE, even with thrombus, will always remain dark. And you can confirm this with your high TI values. So in MR, as you know that, we have so many sequences, so many things, and that is how you can come to a conclusion. So anything which remains dark on late gadolinium enhancement images, even with high TI values, it is a thrombus. While myxoma, an intracavitary mass, pedunculated, sessile, with a stalk in the left atrium, showing some enhancement, variable enhancement, that it is a myxoma. Similarly, to differentiate papillary fibroelastoma from a vegetation, both of them would be small, mobile, attached to valve. But papillary fibroelastoma will show some kind of LGE, and the location, it will be on the aortic side of the aortic valve, while vegetation would be endocardial, and since it will be avascular, there will be no uptake, no contrast enhancement on LG images as well. Coming on to another intracavitary lesion is a lipoma. And as you see, lipoma, since fat will be always seen on those fat suppression very clearly, this kind of lipoma probably you can appreciate on the T1, T2 images. So they are encapsulated tumor, which are composed of mature fat cells. It could occur in subendocardium, subpericardium, or myocardium. It can occur in the left ventricle or in the right atrium as well. Usually they are asymptomatic, incidentally detected on 2D echocardiography, and hence the cardiac MR done. Usually benign, but sometimes depending on the location, they can cause arrhythmia. So now just let us look at one interesting case. So this was a young male, and incidentally there was a mass which was detected on 2D echocardiography. And what you see over here is a well-marginated, smooth lesion. Signal intensity is similar to adjoining myocardium, and it is attached to the free wall of the right ventricle. These are the short axis CMR images. And as you can see over here, the mass is there attached to the right ventricle. The LV-RV function is well preserved. There is no infiltration, and there is no extension into the cardiac chambers. These are the perfusion images, first pass perfusion images. Again, very important that you make sure that you cover the perfusion images where it passes through the mass. And this is what probably you can see that it is showing mild enhancement on perfusion. But these are the late gadolinium enhancement images obtained after 10 minutes. And you see that there is intense post-contrast enhancement. So something in the muscle which is showing enhancement, which could be like it's a fibrous tissue, because any fibrous tissue will pick up the contrast on late gadolinium enhancement images. So this is a fibroma, which is an incidentally benign tumor. There was no uptake, mild uptake on first pass perfusion, but significant delayed enhancement on LG images, which persisted, so that you know that it is a fibroma. Other tumor probably which could occur in the mass would be rhabdomyoma, but rhabdomyoma will be like a muscle. So it will again null, it will remain black. But fibroma, since it is a fibrous tumor, it will be bright on LG images. One other tumor probably, in case if there's a tumor which is showing hyper enhancement, you can think of hemangioma or a paraganglioma, which would show intense enhancement. So these are the common tumors, common benign cardiac tumors we come across. Now let us go through some malignant neoplasms as well. Malignant neoplasms, again, primary cardiac malignant neoplasms have a poor prognosis, which the list is like lymphoma, angiosarcoma, lipomyosarcoma, or anything like this. When do you call that a mass is malignant? The same criteria how we do it for the other systems. Large size, that is more than 5 centimeter, irregular, ill-defined borders. Whenever there is a direct invasion through the tissue planes, multiple lesions, that will be another thing. Whether there is a pleural or pericardial effusion, or if the mass itself is heterogeneous, as you see over here, because there will be some amount of hemorrhage, necrosis, and a pericardial effusion. So all these structures, all these features, probably you can make note of this, and which will suggest malignancy. Let us look at one case. So this was a 53-year-old female with severe dyspnea and cough. She underwent chest X-ray, 2D echocardiography, pleural effusion, and some mass behind the left atrium was detected. So you see over here that there is a mass which is exophytic mass, which is actually compressing the left atrium. It is lobulated, large mass. The signal intensity is similar to adjoining muscle. There is pleural effusion, pericardial effusion, short axis CMR images, and you can actually see that the lesion is actually extending into pulmonary veins. There is loss of fat plane with adjoining structures. Though the LV function is well preserved, but there is significant compression of the atria. There was a pleural-based component as well, along with massive pleural effusion. So, large irregular mass, not respecting tissue planes. It is extending into pulmonary veins, extending into the pleura, pericardial effusion, and just look at the intense heterogeneous post-contrast enhancement. So all these features were suggestive of malignancy. And what you can see over here, that there was nothing, no invasion into the left myocardium. This is the left ventricle, but the lesion is actually heterogeneously enhancing, and it is causing extrinsic mass effect on the cardiac chambers. This is the PET, which showed an intense uptake with a necrotic component. And this was the biopsy, which showed malignant spindle cell neoplasms, like a sarcomatoid carcinoma. So this is how a malignant cardiac mass looks like. Angiosarcoma is also one other common pericardial mass. So those are the things. You should also look at some common location. Probably this is a nice article where it actually shows that, for example, in left atrium, whenever you see a mass, these are the common tumors like a thrombus, myxoma, all this would occur. Along the wall, it could be fibroelastoma or vegetations. In the ventricles, in the cavity, probably you should think of, when it is intramural, you should think of fibroma or a rhabdomyoma. So all this probably, the common location probably can give us some clue. Going on to another case. So this was a lady who was 65-year-old female presented with edema of the right lower limb. And what you see over here is a lobulated mobile mass near the tricuspid valve annulus, which is prolapsing into the right ventricle. So how cardiac MR can actually tell you the shape, the functional characteristics, what is it doing to the adjoining structures. These are the short axis CMR images. Again, what you can see that the mass has some front-like margins. The signal intensity is similar to adjoining muscle. There is some infiltration along the right atrial wall. If you can see this is the mass, but along this wall also there is some hypertrophy or some thickening. So there is some infiltration, so which is not looking like a pure benign mass, a large mass, and you can actually appreciate the infiltration over here, which is prolapsing into the valve. There was some vascularity on the perfusion images, if you can appreciate over here. And there is some patchy delayed hyperenhancement. And this hypertrophy along the right atrial wall is also showing some enhancement. So benign or malignant, and minimal pericardial effusion as well. Yeah. So what are any clue? Benign or malignant? Yes. We did every cardiac MR scan. Whenever you are suspecting a mass, always do a scan with inversion high TI values, with high TI 600 or 850, depending on your scanner, and also take CT sections as well. So when we did the CT sections, incidentally, probably we saw that patient, apart from the mass, there was a lesion in the right breast as well. So this lesion probably, which when we repeated the post-contrast MR images, it was showing some enhancement. It was an enhancing lesion which was there in the breast with smooth margins. This was the bilateral mammography was repeated, in which we can see that there is an asymmetric density, probably partially obscured margins. On the sonography also, not characteristic of a complete, malignant mass, but it was not looking benign as well. And this was the PET. The cardiac lesion showed significant PET uptake, and even the breast lesion showed uptake. And can you appreciate all these lymph nodes all along the chain? And remember, patient had edema of the right lower limb. So maybe all these lymph nodes were compressing, and that is why she had edema of the right lower limb. So what is the diagnosis? Lymphoma. So it was actually a lymphoma which had metastasized to the heart as well as to the breast. So this was an extranodal non-Hodgkin's lymphoma. The clue is, whenever you see some abnormality, don't limit to itself. You can find some clues which are, in the extracardiac structures, and probably finally this you can help the clinicians and give them the diagnosis. Yeah, so that is an advantage probably how radiologists, probably that advantage we have compared to our clinical, because we can look beyond the heart as well. So secondary cardiac neoplasms, 20 to 40% are more common than primary neoplasms. Usually they are most commonly referred to a cardiac CT, so then they do not count to MR directly. They have pericardial and pleural effusions. Typical modes of spread, whether it could be direct invasion, retrograde lymphatic invasion, or some hematogenous seedling, or a transvenous extension. Lung, lymphoma, breast, esophagus, all these tumors, primary malignancies can metastasize to the heart. So to summarize, probably how you should approach a cardiac mass. So whenever there is a suspected cardiac mass, you have your anatomic imaging with your HAST and CNA imaging. Make sure that you rule out all the pseudotumors, pseudomass, normal variants. In case if there is a mass present, tailor your protocol. Make sure that you have good quality CNA images, perfusion images, LG images. Thrombus should be ruled out with high TI images. Benign neoplasms has certain characteristics, and malignant neoplasms characteristics we have seen. So make your own mind map from the location, whether it is in the cavity, whether it is there in the mural, in the muscle, or in the epicardium. Characterize the lesion, whether it is fatty, cystic, solid. Talk about the vascularity and enhancement. And finally, probably you will have some clue. Thank you. Any questions? Yeah.
Thank you so much, ma'am, for this wonderful presentation. Now we proceed to our next speaker, Dr. Vijay Nori, sir. And sir will be delivering talk on cardiac MR in inflammatory cardiomyopathies.
Thank you, Priya. That was a very clear and very lucid presentation on masses. Students don't have any doubts. Students or delegates don't have any doubts on cardiac masses? No doubts? Okay. So let us come to the next topic which has been given to me is inflammatory cardiomyopathy. So before that, this is there because I gave a presentation on inflammatory cardiomyopathy in one of our IACA lectures in Lucknow. So that's why this is there. But even then, IACA is Association of Cardiac Imaging, International Cardiac Imaging. Try to become members of this and enjoy the benefit of good learning and teaching both. From cardiac imagers all over India. So inflammatory cardiomyopathy is the new terminology that has been used to encompass two conditions known as the acute myocarditis and chronic myocarditis, or it is now known as acute myocarditis and chronic inflammatory cardiomyopathy. Now, if any one condition which is there, which has a lot of role for clinical and biochemical markers, that is myocarditis. Because myocarditis is a combination of history, ECG, cardiac marker, that is high sensitivity troponin, CMR, PET, and endomyocardial biopsy. All of them put together will lead to a proper diagnosis and prognostication of a case of myocarditis. Now, there are clinical scenarios are there. I'll show you what are the clinical scenarios. But even before that, let us look at the causes. There are a lot of causes, various causes. Very busy slide for myocarditis or inflammatory cardiomyopathy, acute versus chronic. There are infections like viral, bacterial, fungal, parasitic. Non-infectious like toxic, genetic, and autoimmune. SLE can produce. Thyrotoxicosis can produce. Cancer chemotherapeutic drug can produce. But among all these, if you ask me which is the most common cause, is viral myocarditis. Viral myocarditis is the most common cause. Very common, because viral fever is common. Viral infections are common. They keep mutating. No matter you take any number of vaccines, there is mutation. So viral myocarditis is the most common cause, number one. Viral myocarditis occurs as a part of the viral infection, might involve the heart without your knowing, and even goes away without even having any sequelae. Even if acute myocarditis occurs, there will be acute myocarditis at that point of time when we have seen in COVID that a lot of viral infections used to produce high troponin levels. They were presenting with this systemic inflammatory disease, MISI they used to call, multisystemic inflammatory disease. So in multisystemic inflammatory disease, especially COVID, used to produce a lot of inflammation, very high HSCRP. Some people used to have high troponin values also. They had myocarditis, but all of them did not land up with heart failure. All of them did not land up with chronic inflammatory cardiomyopathy. That means while myocarditis occurs, it might be asymptomatic or symptomatic. Symptomatic, I'll tell you what are the symptoms, and it might go away without any sequelae, or some of them might end up with dilated cardiomyopathy. So dilated cardiomyopathy is one of the final common pathways of a lot of conditions, and viral myocarditis is one of the conditions which produce the commonest mistaken for dilated cardiomyopathy, where patient had myocarditis earlier, but now has presented with heart failure. We can't prove it also. We can neither prove it also. So whenever you approach a patient with myocarditis, one of the questions you ask or take from the clinician is, did the patient suffer from any viral illness in the preceding past, in the 1 month or 2 months? If the patient has developed a viral fever, you can attribute his myocarditis to viral myocarditis. Either it might be acute or chronic. So viral are the most common cause. Then comes bacterial, parasitic, fungal, then autoimmune diseases, chemotherapy-induced drugs, genetic cause, yes, especially we were discussing in our ISA group, there is a desmoplakin kind of genetic cardiomyopathy, dilated cardiomyopathy, which has insult of myocarditis. They can develop myocarditis and then lead to a various set of symptoms in cardiomyopathy, inflammatory cardiomyopathy. So genetic causes are also there. But anyway, remember that viral is the most common cause, number one. Can you identify the cause of viral? It is this particular viral, you can't. You can't. They used to guess earlier, but they can't. I'll show you how they guess and how they used to identify. So acute myocarditis by definition is 30 days onset of symptoms, chest pain, angina-like symptoms, infarct-like presentation. So they typically present to you with chest pain, and they always are evaluated for myocardial infarction, CAD. Because why? Trop I is elevated. HS trop I is elevated. Now, what is trop I? Trop I is a marker for any myocardial injury. It might be inflammation, infection, or infarction. So troponin I is elevated both these conditions in coronary artery disease, inflammation. So trop I is elevated, patient has chest pain, very typical chest pain, 2D might show some RWMA, reasonable motion abnormality, and they come to you with these symptoms. And CAG is done, CAG is normal. CAG is normal. Coronary angiogram is normal. Then you suspect myocarditis in these individuals, acute myocarditis. And these are the things which you see: elevated trop I values, ST, diffuse T wave inversions, SC elevation can be there, heart block can be there. They come with arrhythmias also. And normal epicardial coronaries or mild CAD on CAG. So this is acute myocarditis, presents with typically with chest pain and infarct-like situation. Now, chronic inflammatory cardiomyopathy is more than 30 days onset of symptoms. Persistent of cardiac symptoms. Number one, troponin can be elevated, and if troponin is elevated more than 30 days, that's a bad prognosis. Troponin is still high, that is bad prognosis. Then the chronic inflammatory cardiomyopathy present with heart failure and arrhythmias. Heart failure and arrhythmias. So those are chronic inflammatory cardiomyopathy. So these two subsets have to be divided. You should know the clinical background. Are we dealing with acute or chronic? They present with heart failure, arrhythmias, other present with CAD or infarct-like symptoms. So PET is a very useful modality in acute myocarditis. For example, take sarcoidosis. PET is the modality of choice in acute myocarditis. MRI can pick up, but if MRI is normal, don't presume it to be normal. PET is the modality of choice because hypermetabolism, glucose, any hypermetabolic myocardium will take up glucose. So hyperaccumulation of the glucose or hot spots of glucose within the myocardium or acute inflammation, be it sarcoidosis, viral, any other myocarditis, acute inflammation, PET is the modality of choice. And what are the key tools here in acute myocarditis, acute myocarditis? You can non-invasive diagnose acute myocarditis and ischemic cardiomyopathy, understand pathophysiological mechanisms to identify patients who are at risk of developing heart failure and dilated cardiomyopathy, prognostication, and CMR has limited accuracy in identifying specific etiology of myocardial infection. If I show you myocarditis, you ask me is viral or parasitic or bacterial or something else, I can't. But if I know that the patient is already taking doxorubicin and he has symptoms of myocarditis, I say that this is a doxorubicin-induced myocarditis or chemical or toxic cardiomyopathy, we can call. So that I can tell you. But beyond which CMR, you can only presume and probably speculate, but not guarantee tell that this is myocarditis. This is the cause for myocarditis. For all the seniors here, there were some examples of mid-myocardial enhancement. If there was mid-myocardial enhancement, it was thought to be parvovirus infection. If there was subepicardial enhancement, it was thought to be because of combination of herpes and parvovirus infection. But later on, it was junked, and they said these are all not right. So it cannot be, you cannot identify viral infection. So it is just you say it is acute or chronic inflammatory cardiomyopathy, and then give prognostication. Ultimate role is endomyocardial biopsy. The endomyocardial biopsy is the one which will tell you what is the etiology. But having said that, even endomyocardial biopsy also has a limitation because the pathogenesis or pathology of myocarditis is predominantly subepicardial and mid-myocardial. And you are doing myocardial biopsy here, endomyocardial biopsy. So endomyocardial biopsy will not be very greatly useful because the pathology is in epicardium. Pathology is in mid-mural. Why I am saying pathology is in epicardium and mid-mural? When you look at an MRI, the classic picture of myocarditis is subepicardial enhancement. When subepicardial enhancement is there, the pathology is in subepicardia. You are doing endomyocardial biopsy. Obviously, you will not get good results. So even endomyocardial biopsy also falls short in diagnosing etiology. But you can say it is myocarditis, but going to etiological diagnosis, it's not so easy on all these modalities. So that is one of the pictures of how they do endomyocardial biopsy. And endomyocardial biopsy is very sensitive for one condition known as giant cell myocarditis, which is a not very uncommon cause of myocarditis, but sarcoidosis 25% is positive, and for lymphocytic myocarditis 35%. So if there's a role for endomyocardial biopsy, it is purely in giant cell diagnosing giant cell myocarditis, and giant cell myocarditis typically presents with a subepicardial pattern of enhancement. So now what are we looking at in MRI in myocarditis? What are we looking at in inflammatory cardiomyopathy? Inflammation pathology has all these scalar, dollar, rumor, functional ratio. All of them are there. All of them are there. And MRI can lead us to a certain extent in trying to identify all the patterns of enhancement, all the patterns of inflammation, all the scalar, dollar, rumor, tumor, functional ratio, all of them can be assessed by doing a CMR. The presence of myocardial edema, scalar, hyperemia, dollar, hypertrophy, focal hypertrophy in acute myocarditis, tumor, and Regional valve motion abnormality is functional ACR. All of them can be assessed with a mark for diagnosis of myocarditis, but not the etiology of myocarditis. So sequences, what sequence is more importantly useful here is a black blood sequence or a stir sequence or edema sequence because in your pathology of myocarditis, edema, Taylor, Dollar, Ruber, functional ACR, their edema is what is more important, and edema can be picked up by stir images. So stir image is very important, number one. Number two, what are the other modalities, newer modalities that can pick up edema in addition to stir? That is T1 and T2 mapping. So T1 and T2 mapping are more robust and objective techniques to pick up edema when compared to stir. But stir is the foundation, basic modality. If there is edema on stir image, and how do you quantify edema? How do you say it is myocardial edema? You measure the myocardium signal to muscle signal, skeletal muscle signal. If it's more than 2, that is edema. But it is only about 60% accurate because muscle can be atrophic, muscle can have fat, so many things. It is not very accurate. But previously, we used to, it was only one of the key images to identify myocardial edema was identify the signal intensity in the myocardium to muscle, skeletal muscle, and say edema is there or not. So then you have got T1 and T2 mapping sequences. We'll see what is their role in the near in the coming set of slides. So this is very important because if you want to diagnose myocarditis, there is a criteria laid down known as Look-Locker criteria, modified Look-Locker criteria. So all of them sat together, all the experts, and they said if these are there, it is myocarditis. It is acute myocarditis. So what are those? In 2008-9, there were some sequences, and the sequences are based on T1 and T2. T2 is edema. T1 is enhancement, hyper enhancement in early phase. What is hyper enhancement? Again, because of inflammation, there is hyperemia in the myocardium. Hyperemia can produce leak, capillary leak, and contrast extravasation, and produce early gadolinium enhancement, known as EGE or early GAD enhancement. So in 2009 criteria, the criteria were: one is edema, one is early GAD enhancement, and other is late GAD enhancement, subepicardial enhancement. So if either of 2 of the 3 are positive, then you identify it as a myocarditis. In 2018 criteria, because the edema is subjective, then early GAD enhancement is not seen all the times. That is why they gave the criteria a different color, and now T1, T2 mapping have also been added into the criteria for myocarditis, and any of these criteria, T1 and T2 based. T1 is T1 mapping, increased T1 values or ECV fraction, and T2 based are T2 relaxation time, that is T2 mapping sequence. If it is there, any of these sequences, 2 are abnormal, then it goes into favor of myocarditis, acute myocarditis. So remember, late Lewis criteria, 2018 is the latest one, which has included T1 mapping and T2 mapping sequences and ECV as the markers for myocarditis than the arbitrary and subjective markers like signal intensity ratio of myocardium to muscle and early GAD enhancement. Now, if you take the impact factor on diagnosis of myocarditis, what are the most dependable characteristic and then least dependable? So most dependable LG pattern is LGE mid-mural to subepicardial. That is the most dependable pattern, that is most diagnostic and most specific for myocarditis. Then comes edema on T2 weighted images or T2 map images. Then comes elevated T1 map values and ECV, tissue injury and edema. Then comes LV dysfunction. All myocarditis need not have LV dysfunction. Then comes early GAD enhancement or capillary leak, and last but least, pericardial enhancement. So if you remember, the most specific criteria, CMR criteria, is LGE, subepicardial to mid-myocardial. Then comes T2 mapping or myocardial edema. These 2 are very important. Then comes elevated T1 map values. So this is the typical enhancement pattern that occurs in various myocarditis. But by and large, you remember that most of the myocarditis have subepicardial to mid-mural, outside to inside, centripetal pattern of enhancement. Ischemia is centrifugal, subendocardium to outside. All non-ischemic are from outside to inside. Especially myocarditis is subepicardial to inside, to myocardial, mid-myocardial. Whatever I have drawn or read are the enhancement patterns. So what is the sensitivity and specificity of CMR in ischemic cardiomyopathy? In acute myocarditis, if it is like infarct-like presentation, almost 90% accuracy for acute infarct-like presentation in by CMR. Patient has edema, patient has high native TMAP values, high TMAP values, and enhancement. But whereas if you go to chronic cardiomyopathy, ischemic cardiomyopathy, inflammatory cardiomyopathy, who present with heart failure arrhythmias, CMR has very low specificity. So CMR can only give you a pathology, give you a morphological information, functional information, but not an etiological information. So knowing this, let us see some examples of myocarditis. Now, this is a patient, young patient, 30, 35-year-old patient with chest pain, significant elevated troponin values, 15 days. They suspected CAD. CAG was done, normal epicardial coronaries, 2D normal RV function, no RWMA, to rule out myocarditis. Now, let us go with LGE. You can see here that there is a, in the anterolateral wall, mid-anterolateral wall, there is subepicardial to mid-myocardial LGE. One criteria has been filled up. The other criteria, still, there is subtle edema, very subtle edema in the same location. Now, why STIR is not a very great modality? Why T2 mapping has to be used is because T2 mapping has more objectivity and much more robust and reproducible in picking up myocardial edema than STIR images. Because T2 mapping works on a totally different principle, T2 relaxation time, than eyeballing technique. So here you see on T2 mapping that it is more than 100 milliseconds. Normal on a 3 Tesla value for T2 map values is 45 to 50. It is 100. It's almost 100 here. So one T1 criteria is filled up, LGE, subepicardial. One T2 criteria is filled up, that is T2 mapping value is very high. According to 2018 late release criteria, it is myocarditis. Now, if you see this short axis cine, you can see that there is mild reduction in wall thickness and some amount of edema, hyperintensity. Compare the septum to anterolateral wall, there is some kind of mild hyperintensity signal. That also says that there is some edema. So this is an acute myocarditis. CAG is normal. Two criteria are filled up with Lake Lewis criteria 2018. There is one T1 criteria, enhancement LG, one T2 criteria of high T2 map values or edema. Even still also there is mild edema. So this is an acute myocarditis. Proved acute myocarditis, clinically also proved. So in acute myocarditis, CMR has 90% accuracy. Vis-a-vis chronic myocarditis, you cannot. Now, COVID, we have seen a lot of COVID myocarditis cases. This is a COVID positive, 70-year-old doctor, palpitation, multiple ventricular premature contractions, high troponin values, persistently high troponin values, PET-CT said inflammation in mid-anterior wall, COVID myocarditis, and you can see here that in STIR image, the subtle edema, epicardial, subepicardial. Then this is a T2 SFSA sequence not very greatly picking up. LGE shows subtle subepicardial enhancement there, and these are the mapping sequences there. So actually, PET-CT has picked up inflammation. We are only trying to say that there is not amount of severe myocardial injury or inflammation. It's only confined to a small segment in the anteroseptal wall of mid-LV cavity. Now, this is an example. This is one more example, case example of known follow-up of necrotizing granulomatous inflammatory disease of lungs and vasculitis. 2D nodular pericardial thickening, increased FDG uptake on PET-CT. Involvement of lateral wall villomecardium, left atrium and FDG PET scan. Restricted myocardial movement. So everything was pointing towards inflammatory cardiomyopathy on FDG PET scan. And these are the images. Fourth chamber, short axis, and this is a STIR image. You can see in the STIR image that there is pericardial thickening, lot of edema, also myocardial edema. You can see in the lateral wall, posterolateral wall, there is myocardial edema. So there is pericarditis and myocarditis. And on contrast, you can see that intense pericardial enhancement, epicardial to mid-myocardial enhancement, not subepicardial enhancement. Again, LG, you can see that pericardial, epicardial, subepicardial, mid-myocardial, no subendocardial enhancement. And this is a proven case of granulomatous myopericarditis. It can occur in various conditions. It need not be only tuberculosis. It can be Church-Strauss disease or other connective tissue disorders which can produce granulomatous myopericarditis. And it's a proven case. It's a proven case in the sense we have a lot of modalities to other modalities to help you in diagnosis. Now, chronic inflammatory cardiomyopathy. unlike acute myocarditis, presents with unexplained heart failure or arrhythmias. Heart failure or arrhythmia. So they present with symptoms of heart failure or arrhythmias, palpitation, other things. So this is a case of inflammatory myocarditis, presumed to be COVID. At that time, 2021, the PET-CT was evidently positive. CAD, silent infraposterior wall MI. Silent infraposterior wall MI. Previous study finding of moderate LV dysfunction, moderate MR, moderate PH. CAG in July 2021, normal epicardial cortex. And there is a silent posterior inferior wall MI. Probably because of some kind of vascular involvement, small vessel disease, it has happened. Look at the fourth chamber cine. You can see here, as you see in the wall motion, that there is biventricular dilatation, mild dilated right atrium. There is variable thinning of myocardium, predominantly in the lateral and inferior walls. Septum is okay. Apical and mid septum are thinned out. You can see the short axis, same thing. Septum is okay. Wall motion. There is hypokinesia of the anterolateral and posterolateral walls, more of posterolateral wall. You come to LGE, you have got a variety of pattern of LGE, mid-myocardial, subepicardial to mid-myocardial, subepicardial to mid-myocardial, not subendocardial, predominantly outside to inside, outside to inside. So, if you ask me sarcoidosis, I will say it is sarcoidosis. I will say it is sarcoidosis because I don't have proof that it is not sarcoidosis. Again, typical pattern again sarcoidosis. So, the point of CMR here in chronic inflammatory cardiomyopathy is etiology can't be made out. Because I know it's a COVID myocarditis, I presume this to be sequelae of COVID myocarditis and workup for sarcoid is negative. I presume it to be a chronic inflammatory cardiomyopathy because of previous viral myocarditis. And this is what has happened. Now, what has happened now? He is developing infarcts. He is developing chronic infarcts. He is developing a lot of fibrosis, LV dysfunction, and arrhythmias. So this is how the chronic inflammatory picture is you see as dilated LV, regional wall motion abnormality, focal akinetic or hypokinetic segments, enhancement subepicardial to midmural. Can you say it is sarcoidosis? I can't say. Can you say viral? I can't say unless there's a proof, unless there's a biopsy. So that's how the specificity in chronic inflammatory cardiomyopathy is less for MRI when compared to acute myocarditis. Then the other case, 31-year female, left side chest pain, SOB, preceding history of viral fever few days back. We got it. Suspected myocarditis, severe LV dysfunction, 2D echo, global hypokinesia of LV, moderate MR, moderate TR, severe LV dysfunction, good RV function for evaluation. There is dilated LV, severe dilated LV. I will call it as that. I will call it as DCM, dilated cardiomyopathy, right? Global hypokinesia, mild MR because of widened annulus. LGE, no LGE, no LGE, nothing. No LGE. Now, in this case, T1 values are higher. Now, normal T1 native values on a 1.13 Tesla on our machine in our center using Molly sequence is 1250 plus minus 20. But here you see T1 values are 1375. The point you remember here is patient was suspected to have myocarditis. There is no proof. There is DCMP, dilated cardiomyopathy. She's got severe LV dysfunction, no enhancement, no LGE, but native T1 values are very high in myocardium. That says that there is diffuse interstitial fibrosis, which LGE cannot pick up. Only T1 can pick up on diffuse interstitial fibrosis. What is the cause of diffuse interstitial fibrosis? Presumed viral myocarditis. Presumed viral myocarditis. So, all the seniors who are doing there, we used to report earlier, we see a DCM, no enhancement or mid-mural enhancement, which is called as sequelae of myocarditis. I'll show you that example. So, sequelae of myocarditis. So, this presumed myocarditis. Now, let us come to other examples also. Other examples also. Now, this is a ring-like LGE, mid-myocardial or subepicardial. Again, one of the typical patterns in myocarditis. Ring-like LGE. Let us see some examples of ring-like LGE. Okay, we'll go to other case and then come to ring-like LGE. Now, this is a 46-year-old female, SOB 4 months, Recent 2D co-finding of dilated LV, global hypokinesia, moderate LV dysfunction, no MR, diagnosis of heart failure with reduced ejection fraction. Look at this. The short axis, cine, there is hypokinesia, global hypokinesia, dilated LV, global hypokinesia. Look at the enhancement, LG here. Look at LG here, mid-mural, global mid-mural enhancement. So this pattern is one of the typical patterns of chronic inflammatory cardiomyopathy, secondary to myocarditis. If this was there, we used to call it earlier as sequelae of myocarditis. This particular thing, if mid-mural enhancement was there, but this need not be seen in all cases of inflammatory cardiomyopathy. Mid-mural enhancement or ring-like enhancement need not be seen in all cases of inflammatory cardiomyopathy. But if it is seen, it was presumably suggested that it could be because of parvovirus infection, and next possibility was parvo and herpes virus infection, but not anymore. And this is one of the patterns to suggest that the patient has chronic inflammatory cardiomyopathy, dilated cardiomyopathy. If mid-mural enhancement is seen, presumably it is because of post-viral myocarditis or viral myocarditis sequelae, and no other condition which can produce this. Sarcoidosis can produce, but sarcoidosis is typically subepicardial to mid-myocardial, but this is purely mid-myocardial. So this, you suggest that you can predict that this post-myocarditis sequelae. Now, one interesting case I'll show you of this lady presented with DCMP, severe LV dysfunction. Previous MP-MRI finding done with us was of NICM, sarcoidosis, suspected sarcoidosis. Received 9 months ATD with steroids. Tuberculosis also they want to rule out. Recent 2D finding of moderate LV dysfunction, global hypokinesia, and there was not much improvement. They wanted to look at improvement in the myocardial function and LG pattern. So this is done in November 2022. This is done in March 2024. EF is 30%, EF is 40%, slightly improved. But the pattern of LG and the amount of LG is not changed. You can see here that there is centripetal pattern of LG, subepicardial to mid-mural, and there is also enhancement along the RV side of interventricular septum. So we told that it was sarcoidosis. It was not proved. The suspected tuberculosis treatment was given. We don't have a diagnosis till now. In spite of ATT, there is no resolution. That means chronic burnt out end stage chronic inflammatory cardiomyopathy cause we don't know. Either it is because of sarcoidosis or some other condition cause we don't know. So MRI has helped us in telling the patient that there is not much of improvement in EF, number one. It's a burnt out disease. There are scars within the myocardium. There is no kind of salvage. And even if you put an ICD, for improvement of LV function, you cannot do anything else. So this patient has to go for a cardiac transplant is the option. So MRI, it cannot give a diagnosis, but can prognosticate and give a direction to the treatment that this patient in a chronic inflammatory cardiomyopathy has got thinned out myocardium, lot of fibrosis, lot of scars. Okay, EF is not very great, not much of improvement of EF. So this patient will not benefit from a treatment for heart failure or arrhythmias, and probably transplant is an option. So that is what MRI is going to help you in chronic inflammatory cardiomyopathy. So what is the temporal profile of myocarditis or chronic inflammatory cardiomyopathy? Acute myocarditis can be healed, okay, and patient can just doesn't have any sequelae. Acute myocarditis can lead to chronic myocarditis, and the chronic myocarditis can present with ongoing inflammation, which you pick up by looking at LGE at troponin values, post-inflammatory dilated cardiomyopathy, no inflammation on T2, lot of fibroid scarring. I have shown you fibroid scarring, LV dilatation dysfunction, and probably fatty metaplasia because of chronic scars. So it can go into chronic myocarditis with ongoing inflammation, post-inflammatory dilated cardiomyopathy, or post-inflammatory arrhythmogenic cardiomyopathy, where they have this typical pattern of subepicardial ring enhancement. So subepicardial ring enhancement can also be seen in chronic inflammatory cardiomyopathy, in addition to mid-mural ring enhancement. And This subepicardial ring enhancement, if you see here, this subepicardial ring enhancement, if you see here, that is subepicardial ring enhancement, if you see here. So again, that's one of the findings to suggest that this patient is developing arrhythmogenic cardiomyopathy. Like I told you, chronic inflammatory cardiomyopathy can present with heart failure or arrhythmias. So heart failure is a chronic here, that is chronic heart failure. Here is arrhythmias, they can present with arrhythmias, that is subepicardial enhancement, ring-like subepicardial enhancement is arrhythmogenic cardiomyopathy, secondary to viral myocarditis or myocarditis. So this is how a temporal profile of myocarditis can take place. We'll not go into other examples. I think I'll stop at this level. So just a recap that there can be acute and chronic myocarditis. Acute myocarditis presents typically like infarct-like situation. Angiogram is normal. Tropi is elevated. And in acute myocarditis, lately criteria 2018 T1 and T2 sequences. There must be edema, LGE, and on T2, high T2 map values. If all two are there, that means it is typical. You can give a tick for acute myocarditis. Chronic inflammatory cardiomyopathy is a sequelae of acute myocarditis. It doesn't have typical findings to suggest etiological diagnosis. It is only prognostication of the cardiomyopathy. Whether the patient should go for treatment, what kind of treatment? Is it suitable for ICD placement or treatment for heart failure or arrhythmias? It cannot give you a diagnosis. Very rarely it can give you a diagnosis. If there is mid-mural enhancement, ring-like enhancement, it is a post-viral myocarditis, but that's a chronic stage, not salvageable. Okay. Then the PET-CT is very, very useful in acute myocarditis. And instead of CMR, get a PET-CT done. You get much more information about acute myocarditis than CMR, because CMR need not have all the times all the findings in Lake-Lewis criteria. CMR can still be normal in acute myocarditis. PET-CT is most useful acute myocarditis. Endomyocardial biopsy is the ultimate diagnostic modality of choice to identify the diagnosis, to etiological diagnosis, but it has its own fallacies. Okay, that's it then, I think. Thank you very much for attention.
Thank you so much, sir, for such an illustrious presentation. Any questions?
I think there must be a lot of questions from this. There must be a lot of questions. Okay, one question we'll have to ask comments from Priya, Ritu, and Suman ma'am and others. Priya, please, your comments. Give mic to Priya, please. Mic, please. Your comment. On my side.
Okay. So basically, I think as what sir has explained, that not only the diagnosis, the pattern of enhancement can give lot of clue. So first thing for the beginners, obtain good quality late gadolinium enhancement images, clinical correlation with, I think, ECG, clinical parameters, what kind of, like for example, sarcoid has basal septal involvement, thinning, and a particular type of arrhythmia with an echo picture, then you will think of sarcoid. In case if there are some lymph nodes, you know that probably, necrotic lymph nodes will be TB. But other acute myocarditis also probably imaging has really helped. I think sir has really covered everything, almost all the pictures. Yeah.
It was a very extensive talk, and I don't think so there's anything left to add. Thank you, sir.
Yeah, my question to you.
Yeah. Yes, sir.
Yeah, my question to Priya is, given a situation, can we diagnose confidently between a viral myocarditis, bacterial myocarditis, or say for example, even sarcoidosis or amyloidosis, all of them, can we diagnose, and what is the accuracy of MR?
Yeah. Sir, so basically not just the images, but putting everything into the clinical picture. So a patient, like a giant set myocarditis, will be a patient in ICU with very bad CRP levels and clinical, he will be clinically, and probably in case if possible to do an MR and you can pick up some enhancement, that would be one thing. But there could be a normal MR and patient could have some indolent myocardial inflammation. So that is also one of the possibility. Like in COVID inflammations, there was not so much of enhancement which we could demonstrate, but there were other parameters like troponin leak and anything which probably we suggested. But not always, but it can give an important clue in most of the cases. I think that is, yeah.
Yes. Yeah. Thank you, sir. I now request our chairpersons for any closing remarks, ma'am. Sunita, ma'am. Okay, thank you so much, ma'am. To felicitate our esteemed chairpersons, I now invite Dr. Suman Singhal, ma'am, to come on stage. Dr. Sunita Purohit, ma'am, to come forward. Thank you, ma'am. Dr. Ritu Agarwal, ma'am.
diagnostic specificity, and that is why it has moved that, these are the criteria. What we are talking is the modified task force criteria, which are used now for the arrhythmogenic right ventricular cardiomyopathy. What happens over here basically is that fatty or fibrous tissue replaces the normal heart muscles. It interrupts the electrical signals and causes irregular and life-threatening arrhythmia. Finally, eventually the heart muscle becomes weak and finally leading to heart failure. It can involve left ventricle as well. So that time, sometimes it can have a biventricular cardiomyopathy involvement as well. Commonly presents between 10 to 50 years. Symptoms are highly variable. Patient can have fainting, palpitations, dizziness, fatigue, shortness of breath, or sudden cardiac death. So whenever we hear those episodes of sudden cardiac death, young male has died suddenly, some marathon runner has died suddenly, maybe they were not worked up enough, there was not detailed clinical history which was taken. So all these things, genetic history, genetic makeup, etc. also comes into consideration. These are the patients who develop arrhythmia. And sometimes even left ventricle can also be involved. So that is what happens. So the diagnosis, what comes over here is on the modified task force criteria. As we have seen in earlier, that in cardiac imaging, the entire thing is based on multiple factors. It is the clinical, ECG, family history, echocardiography, and MR. So this is how, whether it comes in the era of myocarditis, also it is clinical picture is important anywhere. So do not always look at the MR image, always look at the ECG, clinical picture, etc. So all this thing is modified task force criteria. It has the entire criteria which is based on this multiple parameters. And then there are given major or minor criteria. Now let us look at the major criteria through the MR. So first thing is you have to have a regional RV wall or kinase, segmental dyskinesia, and along with your parameters, ejection fraction less than 40 and end diastolic volume more than 110 or 100, male or female. So these are the criteria. In case if it fulfills this criteria, you will have one major with CMR. That is how you know that. So whether it is fulfilling one major criteria or a minor criteria. So cardiac MR just plays role in one major or minor criteria. Patient also requires other criteria based on arrhythmia, ECG, whether in case if there's any NSVT episodes, Holter monitoring, family history, or echocardiography. Of this, when patient has two major or one major or two minor or four minor, then you know that it is a definite ARVC. Sometimes it could be even borderline or possible ARVC. So from MR, we just have to say that whether it fulfills MR criteria of ARVC. So that is how you call about arrhythmogenic right ventricular cardiomyopathy. RV assessment is difficult on 2D echo, and cardiac MR definitely adds value. So whenever you have to come across a picture of ARVC looking like this, always mention about the RV size, indexed volumes, mention about RV as well as LV function in case if there is any fibrosis, and also rule out other causes of RV dilatation, what we have seen earlier. This is a classical ECG with epsilon wave. So in case if you find any of these and you have an ECG of the patient, make sure that you make a look, and in case probably this will help you to confirm the diagnosis. Also, when right ventricular comes, there are so many pitfalls, especially as a beginner. Even I had that, is there a segmental dyskinesia? And then you have to make sure that there are a lot of anatomic variants also. Sometimes you have a pericardial connective tissue, which can join along the free wall of the right ventricle. Sometimes because of the chest wall disformity, RV have an abnormal shape. So it is constant way that you keep on looking more number of cases so that you will know that what is abnormal. There are few certain other challenges because not all the disease develop few of the diseases develop over time. It has a variable penetrance. Sometimes sudden cardiac death is the first presenting symptoms, and there is a lot of overlap with the different cardiomyopathy. No test is gold standard, and there are a lot of qualitative components like accurate assessment of end diastolic volume is also important, which is a very subjective thing. So all these are the challenges, and there are few cases which come to you that, it does not fulfill everything. You will just have one parameter. So recently there was this patient who was son had collapsed while playing badminton and he was in ICU. Since he was a completely, high profile case related to a cardiologist, he underwent all the workup and he was found to that he had this hereditary cardiomyopathy with PKP2 mutation, which is causing arrhythmia. Mother underwent a cardiac MR. Since her genetic study was also positive, she also had segmental dyskinesia, but she had never clinically manifested. Son manifested because he was an athlete. So it could have that, a young patients with an athlete, probably they are more prone for that developing, RV cardiomyopathy more common earlier than their family parameters. So there could be some other family members which are harboring the disease, but which have not clinically manifested. So it is important that you watch for any warning signs, palpitations, any arrhythmia episodes, follow up it on the 2D echo, look for the RVOT diameter. In case if there's, like this patients, in case if there are some segmental dyskinesia, you should keep her on the clinical follow-up. These are the RV segmental dyskinesia. And also it is important that you do not overdiagnose or miss a diagnosis, because there are a lot of people who are overdiagnosing arrhythmiogenic right ventricular cardiomyopathy as well. And then this is a paper in which actually 65 patients came for a second opinion, and none of them, almost 46 of them, had not autopsy confirmed on ARVC. So that is why it is important to develop an expertise, dedicated RV views, so that you are familiar with what are the normal variants, what are the mimics, and making sure that your volumes, functions, everything is accurate, so that you do not over or misdiagnose. Clinically, these are patients are managed depending on the major minor risk factors. AISTD implantation or genetic screening can help. They have to be regular followed up, and last resort is the heart transplant. Moving on to another case. So this was a 60-year-old female who was admitted with fever, and patient also had breathlessness on exertion. 2D echo showed severely depressed LV and RV function, and RV was enlarged. And hence he underwent cardiac MR. And again, what you can see that left ventricle as well as our right ventricle are dilated, and there is depressed function. But if you can appreciate, there are segmental dyskinesia involving free wall as well as the base of the right ventricle, hypertrabeculated RV, and there are this segmental wall motion abnormality. These are the images again, and if you can appreciate, not everything is moving synchronously. There are a lot of parameters probably, which are showing segmental wall motion abnormality. But it is not only the left ventricle. There are some areas of thinning in the left ventricle as well. Long axis images, dilated RV, some wall motion abnormality, and left ventricle is also showing some areas of focal areas of thinning. This is how a dedicated RV views when you actually see the tricuspid and pulmonary valve, which can probably help to look for the segmental wall motion abnormality. And just look at the function, RV as well as LV function, both are significantly depressed. And there is extensive late gadolinium enhancement involving right as well as left ventricle. So this probably, if you can see along the lateral wall, along the right ventricular wall, so all this is also showing some amount of fibrosis. So there is involvement of both ventricles. One other clue that I would like to add, that always compare your cine and LG images, putting them side by side. It is always important that, whatever, so that you do not mistake a normal variant as an LG. You can actually look at the wall motion and LG together. It will increase your confidence. And as you can see over here, that there is so much of biventricular involvement. And on the mapping, there is some fatty deposition in the septum as well. If you can see over here, if you can look at the epicardial fat, and there is some amount of fat in the left ventricle. And this is confirmed on the CT image as well. So this is a case of biventricular arrhythmiogenic cardiomyopathy. Ejection fraction of left ventricle is reduced. Left ventricle is also showing some wall motion abnormality. And you could see that presence of fat in the left ventricle. And the ischemic pattern also was non-ischemic. So there was a non-ischemic pattern of late gadolinium enhancement. So this is a picture of biventricular arrhythmiogenic cardiomyopathy. Padua criteria, as after the modified task force criteria which has come, which is actually divided that apart from this morpho-functional LV criteria, you should also look for the left ventricular involvement in terms of function and LGE. It could be ARVC, left dominant ACM, or biventricular ACM. In case if it is left dominant ACM, patient should have desmoplakin or other gene mutation, what Dr. Noori sir had just mentioned earlier. So whether arrhythmiogenic cardiomyopathy, it could be either right dominant or left dominant. In right dominant, basically what we have seen that segmental dyskinesia, RV end diastolic volume will be more, RV function will be depressed, then it is a right dominant arrhythmiogenic cardiomyopathy. While in left dominant, RV could be normal, but you could see non-ischemic pattern of late gadolinium enhancement. These are the patients also who develop arrhythmia, who could have an arrhythmiogenic or a genetic component, and they could have a myocardial injury, arrhythmic events, finally leading to heart failure. So this is what LV involvement has more arrhythmic risk. So this is there are new concepts which are recently described. So it is important to be aware about that. Thank you. Any questions?
Very nice, Priya. Extremely good talk. I think since Dr. Sanjeev Sharma is here, the cardiologist with us, I think, would you like to add upon something what you want as a cardiologist in RV cardiomyopathy or RV involvement by CMR?
I think MR is indispensable for the diagnosis. Whenever we see a clinical presentation like history of palpitation or syncope and we find epsilon wave, immediately after echo, we refer the patient for cardiac MR. And it makes our diagnosis like 100%. It's a gold standard. So we need to advise for cardiac MR in all the patients in whom we suspect the RV cardiomyopathy or the arrhythmic biventricular or the left ventricular cardiomyopathy.
Thank you.
Thank you so much, ma'am, for this lucid presentation. And now to felicitate our chairpersons, I now invite Dr. MP Goyal, sir. Sir is a senior radiologist in Jaipur to felicitate Dr. Suman Singhal, ma'am. I also request Dr. RP Bansal, sir. Sir is head of Department of Radiology at NIMS Hospital, Jaipur, to kindly come up on stage. Dr. Mahipal Singh, sir. Thank you, sir. Thank you, ma'am. I now request Dr. Ritu Agarwal, ma'am, to take this further.
I would like to thank all our speakers for the wonderful sessions. We are very happy that Dr. Sanjeev Sharma, sir, who is the chairman of cardiology, is here with us. So I would request Dr. Mahipal Singh to please come on the stage. Mahipal, sir, please come on the stage to welcome Sanjeev Sharma, sir. Sanjeev, sir. Sir, please come on the stage. Please come on the stage, sir. Mahipal, sir, please welcome Sanjeev Sharma, sir. I would also request Sanjeev Sharma, sir, to say a few words.
Good afternoon, everyone. And warm welcome for this first Eternal Heart Cardiac MRI Symposium. And I would appreciate efforts by Dr. Ritu, Dr. Suman, and all the leading cardiac radiologists who have come for this symposium. And this is very important to disseminate the knowledge, especially the cardiac MRI is one of the relatively new modality. and which has come up over last almost 8 to 10 years, and it's picking up very fast. And it gives very, you can say, vital information for the diagnosis. And what we can see, there are only few cardiac radiologists who are reporting the cardiac MRI. But I can see there's a good number of radiologists have come up for this symposium. And after that, good talks, we are going to have a one-to-one workshop. That is also very good. And in times to come, I think this modality will pick up and more radiologists are going to report the cardiac MRI. Wish you all a very good luck for the future. Thank you.
Thanks a lot, sir, for your kind words. I would now request Dr. Atul Kasliwal, sir, who is the senior cardiologist at ESCC Hospital, to say a few words, please.
Well, welcome everybody. Well, it's nice to be with you all. Well, definitely cardiac MRI has gone a long way now, and we are fortunate. We have got good cardioradiologists, I would say, with us, Ritu, and previously Dr. Singhal was there with us. And well, as Dr. Sanjeev has told us, well, this modality has really picked up fast within last few years, and we as a cardiologist, we need this branch to be developed, because for making a diagnosis, just I suppose 10 days back I just referred him one case of RV dysplasia, the patient Maheshwari, and because he was just 18 years old and he had 2-3 episodes of syncope at home, and there was no previous history, no previous history of any family history, and we just patient came in the emergency, we did that echo. Well, we find that the RV is very little bit hypokinetic, we weren't sure, but we just referred him, and on the next day we got the diagnosis of RV dysplasia. And he had that LV involvement also, a little bit of LV involvement also. And the next day, we put a AICD on that patient, and he's just hardly 18-20 years old. So really, I welcome all these delegates from the Eternal Hospital. It's really, well, I think we'll have more engagements with you people. And probably I feel this branch has gotten a tremendous opportunity for you cardiologists. And we'd like that this branch should emerge in future. All the best.
Thanks a lot, sir. Now we would go forward with the lamp lightning. I request Dr. Sanjeev Sharma, sir, Dr. Atul Kasliwal, sir, Dr. Nori, sir, Priya ma'am, Suman ma'am, Mahipal, sir, to please come on the stage for lamp lightning. Dr. R.P. Bansal, sir, Dr. M.P. Goel, sir, please come. Sir, please.
भगवती विशेष जाड्या पहा शुक्लां ब्रह्म विचार सार परम आद्यां जगत्
I now request all the senior faculties, Anu ma'am, Meenu ma'am, Sunita Purohit ma'am, Josna ma'am, I'm sorry, I'm forgetting names. I'm really stressed out. All the senior faculties to please come on the stage for a group photograph. Kirti Rana Chaturvedi ma'am, I don't know why I couldn't realize your name. And sir, all the other people who were here for the lamp lighting as well, all the senior faculties, please come on the stage for a group photograph, please. Dr. Ankita, please join us as well. Sanjeev Sharma sir, Kasliwal sir, please sir, aaiye sir. Paresh Sukhani sir, sir, I cannot see you. Sir, please come sir. Am I missing out anybody? Payal ma'am, please come. And where is Dr. Jeevraj? Where is वो सबका एक साथ एक second. Jeevraj sir, are you around here? Oh, Vikram Goyal sir, please come. Sir, please sir, आइए sir. Dr. Jeevraj. Well, ma'am, please आइए sir. Sir, please. Anybody? Kanupriya ma'am, please come ma'am. Please. Thanks a lot, everyone. Now we would go forward and request the representatives from Philips to continue with the session. I would now request Dr. Vikram Goyal sir to felicitate the faculties. Dr. Vikram Goyal sir, so please come on the stage to felicitate the faculties. Dr. Nori sir, please come. एक second, sir. Sir, Vikram Goyal, sir, एक second, please, sir. So please stay. Now I request Dr. Vikram Goyal, sir, to felicitate Priya Chudgar, ma'am. Now I request Dr. Jeevraj Singh to come on the stage and felicitate Dr. Suman Singhal, ma'am. Suman, ma'am. Dr. Jeevraj Singh, please come on the stage.
I now request Dr. Jeevraj sir to felicitate Dr. Mahipal sir. Dr. Mahipal.
Mahipal sir.
I now request Dr. Sanjeev Sharma sir. Dr. Sanjeev Sharma sir to kindly felicitate Dr. Ritu Agarwal ma'am. Thank you, sir. Thank you, ma'am. I now invite Mr. Ashish Sharma, Product Manager for CT Philips India Limited, for their presentation.
Can you hear me? Okay, so good afternoon, everyone. I'll take only 15 minutes, then we will break for lunch. Just bear with me for some time. And it's a quick update on what we have it in our as a company, what we can represent, what we can give as a solution for cardiac and rest of the applications. So, not taking much of time, I will. No, slide is not moving. Here it is not moving. Okay. Okay, I'll see that. No problem. So, as you know, Philips, people first thought of Philips would be Philips is a lighting company, but no more Philips is a lighting company. Now we have completely moved to healthcare business. So over the years, if you see what Philips has done throughout the years, and it is a meaningful innovation what Philips is doing for the solution for as a solution to clinical clinicians and for referring physicians. So if you see the engagement part, what Philips is doing it across the years, like right from what we have, like Make in India concept, we have our Philips Innovation Campus in Bangalore, we have our coil factory in Pune. So a lot of things like development process, the new innovations, what we are doing it in India only. So whatever the workstation, what you see it around this hall, it's being developed in India itself. And that too, we have a big campus in PIC, where we have almost 5,000 plus software skilled engineers are working behind to deliver this solution, not for India, not only for India, but globally, we are the one who is supplying these solutions. Okay, so we should be proud of having this kind of solution as a company. We are delivering it through our meaningful innovations in India itself. So this is just a quick background about Philips and what we are doing it in diagnostic informatics. And for an MR update, what we have it in our portfolio. So usually in an MR, if you see, there will be a lot of challenge in placing the MR. So the main challenge would be to look for a place where you have a quench pipe, where it takes a lot of helium. Like it says that 1,500 plus helium it takes, the magnet takes. But Philips is the first vendor in 2018. What we have done is we have got a new solution in this MRI breakthrough by coming up with the helium-free models. That means there is no helium in 1.5D segment, only 7 liters of sealed pack helium which is available in this portfolio. That means in 1.5D, this segment will help you to put the MR in any of the floors with different shades and shapes. And in 2018 to till date, we have sold like more than 1,000 MRs, 1,000 plus MRs we have sold across globe. And in India itself, we have almost 50 plus MR installed with the helium free, and that too with the whiteboard solutions we have. In 3T, the meaningful innovations, what we have done is we have changed the gradient concept itself. So that's what I'm going to touch base on. So if you see, this is how what we have done is with microcooling technology, we have eliminated the helium concept in MR, which takes a lot of time for installation, for a safety measure also, everything related to this. But the weight of the magnet also got reduced because the helium is completely kind of nil, which is only 7 liters. So this is how it will look without without the cover of. So one clip of it, where how many installations we have across, and we have saved like lot many liters of helium by having this kind of solutions. And in the coming days, all industries are following Fitprint, like our fully digital platform, which we have introduced in 2011. And that was the first, like in Jaipur, there was the first installation in Eternal we had, that fully digital platform that still exists there. And a lot of imaging, cardiac imaging, what we do it in Eternal goes across the globe, and it gets a good feedback because of quality of MR, which is a magnet, and quality of gradient strength, what we have it in our existing IB itself. And that gives you better cardiac images. So if you see the 3T, we have new gradient specs with new gradient hardware, which is basically, usually we have a coil winding technology in gradient, which has a challenge, inherent challenge, like eddy current artifacts, you get it. But with the new water jet cutting methodology, what we have done is precisely we can get we can minimize the eddy current artifacts, and we can achieve the gradient performance to a maximum level. So that is what Elysian X will bring you. And the important part in an MR is you have to have a dual independent RF transmit. The higher the field strength, the more the dielectric shading artifacts. For example, cardiac, if patient comes with ascites, patient comes with dilatation, where the fluid is also there, that causes artifacts when you don't have this independent RF technology in your system. But right now also we have it in Internal. In all our 3T portfolio, this hardware we have it. This is very important in 3 Tesla to have it. So we don't sell without this technology. So if I talk about gradient performance, you can see that infarct there, how well we can appreciate the parenchymal difference, where the infarct is differentiated well with other normal parenchyma. So that is a power, that is the messaging what Vega HP gradient in Elysian X can give you. So higher the gradient, like what we have seen it in Elysian X is 45-220, the amplitude and a slew rate. But if you go beyond that, there is one more portfolio, one more 3 Tesla. In that, what we have is a higher gradient, which is of 65-220. That gives you even higher performance than what we have seen it here. And if you see, what we have done is we have seamlessly integrated our multi-nuclei technology in it. Otherwise, this technology, this applications, if you wanted to use it, you have to do a research, you have to switch back to a research mode, then you have to apply this multi-nuclei. So in an MR, what you do is a photon imaging, but carbon, your phosphorus, your xenon, that also can be imaged here with the coil, with a dedicated coil for this. So that is one thing. And there are a lot of challenges what we have it in the workflow solutions, where the throughput time we need to increase. So one is the speed is a challenge, which we have come up with smart speed AI technology. And in neuro, what we have done is without giving a contrast, you can do a non-contrast perfusion. It's called 3D amyloid proton transfer, which gives you, without giving a contrast, your perfusion imaging. So this is what we have done in improving the speed of MR. The noise we have reduced, the gradient performance we have improved, the magnet quality we have improved. The one part what you have is that how fast we can take the patient out, cardiac imaging or any other routine imaging. What we have done is we have brought our new solution called compressions with AI, that's called Smart Speed, which gives you the acceleration pedal and adaptability of 97% of all the applications which is there. So a few cases of cardiac, since it is a cardiac symphonous. So what I'm trying to display is that how well we can appreciate, even with acquiring the images quickly, and we get a better quality. And the parenchymal difference, you can see it across the change, what we have done, applying each applications of acceleration method. So few cardiac resolution, if you see the productivity also, like improving the quality of images and then doing it quickly with the seconds, what we have mentioned, with the kind of resolution, even the MR, we don't have to compromise on the contrast to noise ratio, say, where cardiac MR is very important, without compromising on the resolution, but still you can reduce the scan time and do it quickly. So one image which I wanted to show you, because this is one of the revolution what we have done now. We are kind of getting a, like, usually we shift the patient for any bone imaging, we shift the patient for CT, screening kind of thing. But now in MR itself, we have a better solution for CT images. So few of the applications you can go through, even in our workstation, we have this case loaded for high-end application for the system what we have discussed today. So I hand over to Ashish for quickly say a few words about CT.
Good afternoon, everyone. I won't take more than 10 minutes. I am Ashish Sharma. I takes care of CT modality for the region. So I'll take you through some of the recent developments in Philips CT. What we observed that our technologists and clinicians were struggling with through the entire process of CT scan, from preparation to high heart rate imaging, especially in 4 centimeter systems. Then radiation dose, how we can minimize dosage, because dosage is a thing which everybody is discussing, and what all the reconstruction techniques, how we can improve the speed of the exam. So we have come up with a AI-enabled system, and all the AI-enabled application in all the steps of the CT scan exam, being from starting from preparation up to the post-processing. So I'll start with the preparation thing. We have a precise position. It's a automatic positioning through AI, through which we have kept a camera above the patient, and we take the recognition points on the entire body, and accordingly machine will automatically position the patient at the ISO center, and we are ready for the scan. So it will actually reduce the overall time, improve the overall consistency, and that will help in the overall workflow of the CT scan exam. Dosage is a very important thing nowadays. Everybody is reducing dosage. So it's an overall journey. If you see, from filter back projection to iterative recon, then model-based reconstruction. Now we have AI-enabled neural network algorithm, where we can reduce dosage by up to 80% from the normal scan. We can lower the noise by up to 85%, and at the same time, we improve the image quality, keeping all the things intact. So if you see, this is one of the example where the brain, you can see it's a 100% dosage at iterative recon, while it is at more lesser dosage in precise image or a AI-enabled recon technique. Cardiac high heart rate imaging is a very important, especially in 4 centimeter systems. Now we have 8 centimeter, 16 centimeter also, where you can do very fast cardiac. But in 4 centimeter, if you see, high heart rate imaging is a challenge. And with precise cardiac, we have improved the high heart rate imaging, because without any human intervention, these artery, the overall image can be improved, the motion can be compensated. So, and this is because of the new AI technique, and this is without any human intervention. Another AI application in our system is precise intervention. Precise is our overall AI suite name, and we have different application inside it. So intervention, it will guide you through the entire process, starting from planning to do the intervention. So it will guide you how much you are deviating from your plan, what is the distance remaining. It will give you the deviation angle also. So it is kind of a robotic assistant you have with your system. we have different technology in terms of spectral imaging. We have sandwich based detector where spectral is always on. So you don't need to do a separate scanning for your normal scan, conventional scan, or your spectral scan. So with one scan, you will get both the images, like your normal 120 kV scan, plus all the dual energy results. Like if you see, and one good thing about this scanner is we can always eliminate probable and can kind of thing, because if you see this is a 120 kV image, nothing is visible in this, but if you have a ready data of your all spectral images, you can definitely see the difference in the image quality and the overall clinical findings. We have a very high-end workstation. We call it advanced visualization workspace, which is a multi-modality, multi-vendor system where we have application modality wise and even your application wise. And one good thing about this is a multi-modality, multi-vendor workstation. So you can fuse different vendor also in this machine, and all the applications are merely zero click or single click. So your post processing would be very fast as compared to other workstation. So thank you. This is from my side.
Thank you, Mr. Ashish and Mr. Stanley. I now request Dr. Ritu Agarwal, ma'am, to deliver the vote of thanks.
So as we come to the end of this lecture series, we have the second part, the workshops are left. I want to extend my deepest gratitude to everyone who's been involved in the process. I first want to thank our chairman, Dr. Sameen Sharma, and the co-chairman, MD, Mrs. Manju Sharma, whose guidance has already, whose vision and guidance has always inspired all of us. And CEO, Dr. Prachish, who has always been instrumental in pushing me beyond my limits. And Dr. Manmeet Makkar, ma'am, Medical Director, ESCC Hospital. A special thanks to a team of cardiologists, CTBS surgeons, cardiac anesthesia, who always ask the right questions and tell us to do better. A team of technicians and the radiology staff for all the hard work they put in. They work off hours when we are sleeping in our homes. And I really want to thank you all for all the hard work that you guys do. My deepest gratitude to our industry partners for funding the entire program, Team Philips for taking care of our workshops and providing us the real workstations. A very special thanks to our marketing team, especially Mr. Nitesh and Mr. Vikrant, who have been working very hard since the time we planned this event, and our event partner, Vision Plus. I also want to thank Dr. Ankita for taking care of the anchoring, and I'm sure I must have missed out a few names, and I deeply apologize for same. It's always the team spirits that win. I thank you all. Thank you all the delegates for being here, for taking time off from your schedule. Now I would like to invite all of you on the stage for a big group photograph. Then we're going to have lunch, and post lunch we are going to have a workshop. Thank you all. Thank you very much. All of you, please come on the stage for a group photograph. Please come, everybody. People from the back, the residents, the consultants, Dr. Mohit, please come. आ जाइए, please, सब लोग आ जाइए. Okay. Can someone call people from outside to please come inside for a photograph, please? All of you, please come.
This is good.
Good afternoon, everyone. We are going to begin with the workshop. Sorry. So everyone is not. We are going to begin with our workshops shortly. So everyone is requested to kindly take their seats, and we'll be having around 6 attendees on one workstation. So kindly be seated accordingly.
So we'll be starting with a workshop shortly. Please take like 6 people on each console. And with the Philips team, I'll be here on the top front console. First of all, the Philips team will run through some applications with you, how to do contouring, volumetric analysis, flow, mapping, and all that stuff that we have spoken. Now we'll show you how the software works. And then Dr. Nori is going to show his cases, 3 cases. So Dr. Nori has a flight at 3. So we'll let Dr. Nori do his cases, and then all of us will show the cases. And once we are done with the cases, even in between when you're reading the cases, if you have any issue, please raise your hand. One of us will come to your console and show you the whatever problem you are facing with. And once we are done with the cases, we'll give you some time with these workstations so that you can practice on them and see it on your own end, how it works. Does that sound fine? And at any point of time, if anybody has any issue, please raise your hand. I'll be there.
Which case, sir?
Hi, just to make clear now, we are doing cardiac MR post-processing on this workstation. First, the case you need to select, you need to go on your desktop, click here, click on to EH. The folder of the name is EH folder. From the left, right-hand side left folder. EH second folder you need to click here. Here you first will go with case number 7. So once you select the case number 7, there's an application, two applications are there. One is review, one is analysis, okay? So you need to select under the review, you need to select MR cardiac suite. Everyone is there? They can able to locate, right? Okay. Once you are there, you just have to click on this MR cardiac suite. First time it will load all the series together in this particular package. First, ejection fraction. So first we are calculating the functional ejection fraction of the in cardiac MR. Who all got loaded with the study? We can able to see all the series there, right? Okay. So this is the news. Basically, what happens is previously the application got developed in a way like you have to go for ejection fraction calculation in a separate application, then perfusion as a separate application, Q flow. So we know and cardiac, we do have lot of function, morphology, Q flow, all the sequences there. Abhirop, so once you go there, this particular suite is designed in a way like instead of going and jumping into multiple application, one single application is there. If you load the study first time, it may load in a 1/2 kind of a view. From here, you can go this label data option is there. Click there and go by 1 screen option. So once you click, your whole screen can be utilized, and now you can see all the series there. The series, if any series is not visible, you can click on this series option. So basically, what are the series loaded here is covered with the color coding, and rest new series are showing in the blue one. You can always replace it, but because this is not always work with the reading part and it requires a lot of timing, so we do have created a hanging protocol. So let's say now you want to see only the functional series. Click on the functional. System will align all the functional series together automatically on your viewer. And now you can play the images, you can compare, see the function images comparison together. Similarly, with this functional hangout, we do have other hangout also. Let's say now with the functional, I do also want to see and compare the functional and the post-contrast viability sequences. So again, system will define all the hanging protocol together and show the functional and the spatial sequences together here. Okay. The best part is once you click here and you can scroll it, it will actually scroll and give the organized view. You don't have to do it anything on your system. System will automatically adjust all this setting for you. Coming to, there's a new feature called finding dashboard. So as we know in cardiac, when we're doing processing, a lot of steps are involved. And we do require one kind of finding navigator where we can save all our results so that later in the printing or in the reporting, we can forward those images or key. So this is what the finding navigator now is called as a finding dashboard. In the previous post processing, we saved couple of result here. This is what you can see. We can just double click and see the result. We can send into post processing part again. And now again, I'll come back to my viewer. Here, if I want to do a ejection fraction, there's one plus button next to the finding navigator. Click on that plus button. So you'll see what are the applicable data sets. So for this particular data set, because we don't have mapping or the Q flow sequences, it is showing function LV and RV, spatial enhancement, and function long axis. So I'll select function LV and RV option. Once click there, it will launch and ask you which sequence you want to do a post processing. For this case, let me select this middle, the second middle short axis images, which is covered with the 12 slices in cinephase. Now click on open button. So it will load this series automatically on your viewer. And now comes here the good part of it, like the new part what we have developed. This is the basically AI-based segmentation. So previously this segmentation required a lot of time and manipulation from the user end. Now, if you click this automatic segmentation, which is coming here with the star mark, just click there. The system will send you a message that it will take around 1.5 minutes for the post processing, and then you just click OK. So that circle is coming off, is basically doing a post processing in the background. What are the segmentation on the LV segmentation, as well as RV also got segmented here only. Post this result, what are the results going to pop up? Still, you do have access to correct it. It is not like we bind you with the AI application, or user always have access to correct it and make it correct segmentation later on also if process not done by the system properly. So I'll just click on one time and then this result will get populated here. And again, the protocol is you have hanging protocol in the post-processing application as well, because we do require a lot of viewing and the formatting together. So these protocol, you can save it later for yours to preference if you want to create your own hanging protocols. And these are the viewer, like what kind of, currently this viewer is showing your automatic selection of end diastolic and end systolic by the system itself. Then below they are showing the reference images. These reference images, again, I can shift it by clicking it here. And because it's a server-based architecture, currently what we have implemented is one server is there. And from this one single computer, you guys are all accessing on different computers. This is required when, as a center, you do require a multiple post-processing workstation instead of one, and everyone can collaborate and work together. So now that waiting symbol gone. And now all the post processing part is done. Now you can see even on the basal side. So mainly we got the problem here. It's the apex, like currently in the apex, if there's a small flow also, it will show and it will ask you like, it will draw on the endo counter here. If I don't want it, click on the delete from all phases in one click. And it's got deleted because other slides is not showing any endo or epicardial cavity. Now I'm coming up, and you can see the correctness of how the better way it is got added here. If I want to correct, when I hover my mouse here, it will show multiple small points. So I can go, I can correct it. Like in this case, I do want to include this much only. I do not want to include any valvular blood flow. So I'll correct it. And after correction, I will just make it right click here and say propagate counter. So it will correct in the other end systolic and diastolic as well. Now, again, you go back. You can correct it further in the basal slices. Here, like if you see, again, I do have option of like my other end systolic is not showing any AP counter kind of cavity there. So what I'll do, I'll just do a right click and delete from all the phases. So now I do have all the result ready with me. Here, if your hospital system configured with the HIS, automatically patient height and weight will come here. If it doesn't, then you can able to enter these values. So for this example, let me keep it 162/80 and click on confirm. The newer method is now other modular, other than modular, you have other BSA formula also enabled in this version. And now my results are ready and my LV cavity results and those parts are ready. Here I can see the graph where over the time, what is the volume in the LV cavity is there. So I can always able to see and correct it. What is my correct end systolic and the end diastolic. So let's say in this slice, I don't want this to be end systolic. So here I can able to match it properly and then right click and make it as a end systolic and diastolic part. So I can get the correct ejection fraction if it is not. Second, the 1.5 minute, whatever the time it has taken, it has calculated your RV as well. So I'll just do a one click and now you see the magic of the AI is this RV segmentation was literally a tough situation for every user. Till now, whatever we have seen. Now you can see here the RV segmentation done by the AI automatically here again. And now I do have a result available for both of the segments. My RV and LV, both of the segmentation done, ready for the processing. Here, if I want to see the AHA kind of result, what I can go again, go back to LV cavity, LV post-processing option, and then I'll select here. This is my spoke wheel option. Just click. And then if you want, you can correct it further. In this case, I do not see any requirement for the correction. So I'll simply go for the both option. And now my results are updated with the AHA segmentation. Now the entire hanging protocol is designed in a way like if you want to see RV and LV together, I'll tell you the part is like whenever we are talking about the RV segmentation, we always recommend till now to do on an Excel. But with this new method, my RV segmentations results are coming much better, even with the short axis acquisition as well. So I can able to see the different hanging protocol or layout together and I can put into report and the finding navigator here. That's easy it is. Now, second part, for the same patient, we have seen post-contrast enhancement. So what I'll do, I'll try to quantify these enhancement result, okay? To quantify that, again, I'll click on my plus button. I do not require to go any other application. Click on this plus button, select the enhancement option. So this is basically viability quantification. Here it is showing me two sequences which is compatible with this post-processing. So one is like early enhancement, one is the late. Let me select the late enhancement sequence. Click on open. Now here, because late enhancement sequence is done in total 9 or 10, 15 slices acquired here. In this case, I do have the referral images available already. What I'll do, I'll just, there's a task guidance. First, we need to do a segmentation. In this segmentation, instead of drawing a ROI or the AP counter or the ND counter, I'll just click on the import counters. So whatever the counter drawn on the short axis, it will get automatically propagated in this series. So again, your time got saved. Instead of drawing multiple counters, this got automatically calculated here. Now here, with the segmentation enhancement, I have three methods. One is the standard, which is full width half maximum. Second is the reference ROI. So let's say if I wanted to say, okay, out of this myocardium, let me select, this is my normal myocardium. So what system will do, automatically, what are the rest of the enhancement options come to myocardium, it will segment automatically. And it will show you as a result summary here. The newer calculation is no reflow method also got added in this particular calculation. And we have the transmissibility index. If you want to go with a different, again, hanging protocol, you can see the polar maps here, okay, with the segmentation. If you want to do a correction, like system is selected wrongly any intensity, you can able to delete it or add it from your end. So again, this is the viability quantification part. If this part is done, then I'll ask you to process the second case, which is the case name is cardiac from your side. So open the study, start processing like how I shown. If any help is required, let me know. So I'll select my MR cardiac case. My previous post posting, it is asking whether I want to save or not. I don't want to save it.
Yeah, I think we'll just see one case now. We open Yugal Kishore. Yugal Kishore on your workstation. Yugal Kishore. Actually, in what I have given, everything is there. I just have shown multiple here. All the companies there, everything is there. Okay, have you opened? All of you opened? You open it. You open in multimodality viewer. Please show them how to open multimodality viewer. Open the case in multimodality viewer. Don't go to MR cardiac suite. Go to the right side of it. There is multimodality viewer. Open that in multimodality viewer.
Just double click on the study, it will load into multimodality.
Directly double click, go to multimodality.
Yeah. In the patient name, double click.
Patient name is Yugal Kishore Yadav. Yugal Kishore Yadav. Have all of you opened? Please raise your hands who got opened, who have opened in multimodality viewer. How many have opened it in multimodality viewer? No? I think we should help them. Someone should help them. Opening in multimodality viewer. Instead of doing function, everything is there. How many have opened, please? Lift your hands, please. How many groups have opened? Multimodality viewer. Okay, 1, 2. Others 3. Okay, so we'll start going it from here. We already worked up this case beforehand. So the first image, what we are showing is the results. Results which have been populated after doing the function analysis of LV. Results have been populated. And for body surface area, it has been indexed volumes and indexed mass has been done. And this is the case of HCM. You can see that EF is here 61%. You can see end diastolic mass 149.5 grams with papillary muscles 195.5 grams. So one point you should remember here that there was a controversy on whether to include papillary muscle mass in calculating the LV myocardial mass or not. So if you have got a software, the earlier feature was they did not have enough software advantage to calculate the papillary muscles also. And papillary muscles were considered to be a part of the endocardium of the blood. But now there are good softwares to evaluate the papillary muscle mass also. You can always mention that end diastolic mass, including papillary muscles. You always mention that. That's an important point there. Okay. For your information, the papillary muscles form about 25 to 30% of the LV mass. So without papillary muscles, it is 200. Without papillary muscles, 170, 160. With papillary muscles, 200. So whenever you mention a mass, always make a comment that it is with papillary muscles, including papillary muscles. That's very important. Okay. Now, I'll just deviate. I'll ask 3 people here, Suman and Priya also, with papillary muscles, without papillary muscles.
Without papillary muscle.
So there are 2. So people do without and with papillary muscles. That is why you mention always with and without papillary muscles. Now the recent concept is if you got a good software to include papillary muscles. Rohit, is it including papillary muscles?
Yes.
And how robust is your technique? How good is your technique? I mean, in assessment of papillary muscle mass also.
So the quantification is automated. The user doesn't require any interaction.
Okay. So in Philips software, there is with and without. So other softwares, I don't know. In Circle software, you can add always. You can always say include papillary muscle, it will include papillary. Yeah, it is easier. But what happens of late? See, we are all being carried away by 2D echo formula. So whatever 2D echo does, we are doing. So here, with the advancement of CMR in calculating papillary muscle mass, if you add it, probably it might give more accuracy. Okay, but you mention it with papillary muscles, without papillary muscles, without ambiguity, mention with papillary muscles, without papillary. Okay, and then obviously for the body surface area also.
What is the clinical significance of measuring accurately myocardial mass? So I think I have seen that sometimes those patients who develop chemotherapy-induced cardiotoxicity, their papillary muscle mass means, the myocardial mass decreases. And that is one of the parameter that, patient is developing effect. So then it has to be matched with clinical thing that, your mass also is important in few of the cases. Any other place you can think?
The athlete's heart and all, heart, it is in heart.
So athlete's heart versus hypertrophic cardiomyopathy, important.
So you go back and read about the papillary muscles, follow whatever you are following as per your institution protocol. But if in doubt, mention with and without papillary. That will solve the issue, complete issue.
So we are not going into detail about how to do the functional analysis.
Yes.
But it is important that what we have seen that endocardial contouring, checking the end systolic and end diastolic phase,
and drawing your endocardial contour in the short axis from base to LV apex. And as Dr. Ritu had mentioned that it is like multiple slices. Those slices have to be 6 to 8 millimeter thick, no interslice gap. Make sure that basal slice is counted properly. So whenever it is covering at least 3/4 of the circumference is covered by myocardium, you should include.
Yeah, that is important.
Exactly. It must cover more than 70% of the cavity. I do. Okay. If you are seeing, you go to the viewer and open, you can
plus or 5 to 6 studies will calculate whether it is, 15% or more. Apart from that, even visual assessment. So
basically, by the 2020 guidelines, two prognostic signs you have to see in the HCM. One is wall thickness more than 30 millimeter, and if it the analysis more than 15% of the myocardial volume. So if these 2 points are there, then these are the prognostic signs. So basically, we do the CMR for these two prognostication and to look at All of you, please open case 1. सबसे पहले सिमरन देखिए, सबसे पहले हाँ पहले बायोलॉजी से दिखा हाँ दिखा So there is some change, just wait. First of all, see, first of all, when you start the scan, you take the scout and you take this black or white blood sequence from top to bottom. So always try to roll this sequence first so you can know the whole anatomy of the heart. Normally we take it from the apex to the base of the place. Then we start taking these. This is like this. You can scroll to the whole thing. So like the way you're doing a thoracic CT, you get an idea of what is happening, no? The aorta is dilated or not, the PAs, how are the PAs, what are the, you get a broad idea of the whole chest and the heart and everything. So it helps you certain times to look at the lymph nodes and all, extra structures. Now go to the heart and then we look at the cine when we are doing the viability. Your short axis cine. So this is a 2-chamber cine. So here we see always the anterior and the inferior wall. So we are seeing they are pretty good, moving nicely. And we see the mitral valve here. Then the 4th chamber. So this is the 4th chamber cine. Exactly 4 chamber nahi hai. Haan, this is the 4 chamber. So here we are seeing the mitral and the tricuspid valve, both the LV. So we see all the, as Dr. Priya said, look at the wall motion, look at the center of the cavity and see how all the walls are moving through all the planes of the 4 chamber. So you see the septal wall, the lateral wall, the RV wall, the LV apex. So all these walls are seen very well in this. And then you do the so you can see the 4 chamber now. The septal wall, the lateral wall, the LV apex here, the RV wall, both the valves, the interatrial septum, atria. So all this motion, wall motion is seen very well with the 4 chamber. Then you go to the short axis and this is you 24. So now we are looking at the short axis. So from the basal slice, where we are seeing the valve, the mitral valve, and then we see all the slices here. So we can see that there is definitely some hypokinesia in the septal wall. You can appreciate that this wall is moving, but this is not moving here. So there's definitely some hypokinesia in the septal wall and the LV apex. And though the RV is moving very well. So basal, the septal wall was fine, but mid to distal, the septal wall is hypokinetic. And this is what Dr. Priya said, that if more than 75% of the myocardial thickness is there, you have to include that slice in your volume calculation. Now we go to the whole thing. No? We can keep the cine and the contrast together. PSI. See, normally all the cines and with the post contrast, you keep them together and then you see whether they are hypokinetic or not and how much is the contrast enhancement there.
Generate all three sides of the
Okay.
ideas to connect it to it.
Okay.
Always we connect here when we want to use PSI. Now, both of the things.
Both are not synced. We need to be synced together. So this is how we sync them together. Okay, so you can see where we were seeing the hypokinetic here, this, and here we are seeing the contrast enhancement in the same part, the distal septal wall and the LV apex. As we are seeing, this is a mid septal wall, anterior septal wall, and we are seeing the subendocardial enhancement, and it is kind of 50%. And like on one focus, it is more than 50%, but otherwise it is mainly less than 50%. And it is definitely hypokinetic. So moderate probability of recovery, what we will call in this, though we will see the four chamber and the the long axis as well for the other walls.
But most important is that it is subendocardial. Like earlier you saw it was patchy and it was mid-myocardial. So mid-myocardial is cardiomyopathy. Ischemic heart disease would be subendocardial and it would fit into a coronary territory. So like this is fitting into LAD territory. So that is how you can make out that it is ischemic or non-ischemic. Four chamber views, you can actually see the entire anterior wall and apical segments. So this is classically into LAD territory, in fact.
So here we can see the post-contrast images. So here see this, how the LV apex is transmural enhancement is there. So this segment is like very low probability of recovery, though we are seeing this subendocardial less than 50%. So you have to report in your report that how many segments are showing the ischemia and how many segments are good probability of recovery and how many are very low probability of recovery. So this is how we are seeing this. This is hypokinetic septal wall as we saw in the short axis as well. This is the four chamber showing the same, and the subendocardial enhancement is there in the septal wall and the LV apex. That is the LAD territory which we are talking about. The two chamber shows us the anterior and the interior wall. We can see the two chamber also.
So in ischemic heart disease, look for thickening, thinning, look for wall motion abnormality, look for late gadolinium enhancement, and in case if there are any thrombi or anything like that.
So look at this, the anterior wall is moving very well. But there is not much of hypokinesia. There was hypokinesia in the septal wall. And here we are seeing this minimal subendocardial enhancement here. This is again the LAD territory. So mid to distal, anterior wall also there is a subendocardial enhancement which is there. And this is the LV apex which we are talking about. So This is a case of viability in which we are seeing the LED territory ischemia which is there. Post-processing, the scar quantification you can show.
So scar quantification, if you do it, you can do on this case actually. If again, I will rehearse the same what I told you. In the same way, you can start again. This case you already seen clinically. Now we'll talk about how the post-processing work for this case. So now the study you have already opened, I guess, or you already open. Okay. So you click on the viewer part. And then from here, you can click on the all series.
So whenever you're doing a bio,
So in this case, like how ma'am was navigating. So these all navigation now we enable with the software. Let's say you wanted to see only the functional series in the start of your study. So click on those layouts which is already available and it will arrange all the images for you together. Now, if you wanted to see the spatial enhancement or post contrast only, again, similarly, you can go ahead and do this. Particularly in Philips, they used to generate the raw data image as well. So if you're using post contrast sequence, which is a phase sensitive inversion recovery, PSIR, then here you need to click and change the image to corrected real. This is the image basically you need to look in for the viability images. So there the contrast will come much better and you can able to differentiate the contrast uptake in these sequence, particular series actually. Now here, if I want to do a quantification, one is you can click on this plus button. So you will see this all post-processing application enabled for you. Like it's a function LV and RV is for your ejection fraction. Q flow is the quantitative flow assessment. Spatial enhancement is for the quantification of the viability. Like what are the star quantification is there. That also you can make it from the system. Mapping, the best part of this is a multi-vendor support. So even if you have a review case, let's say from other vendor, this is GE or Siemens, you can able to load the data, process the data, and get the qualitative review together. And then the mapping now we enable with the synthetic ECV mapping. So that also is enabled on this particular version and post-processing for temporal enhancement. So let's say like we click on the function LV and RV. So it will ask me which sequence you want to do in post-processing. So obviously I will go ahead with the short axis images and click on open option. So once you load first time, if the post-processing already
open it up.
Everybody open? If the post-processing, you open it up and first time you made any post-processing or maybe your technician done it, all the post-processing result is already saved for you. You don't have to do anything. You can go ahead and review your images and do the correction. So as we were talking about, so basically we have taken entire short axis for this LV cavity here. Okay, you can see the reference images below. This particular LV cavity, we have cut down images and totally in this case, we have drawn total 12 images. 12 slices we have taken. And in this 12 slice, now I can able to draw my epic counter or endo counter, which is already done by the system itself. Again, let me go and check everyone, like every slice I'll go ahead and check. Okay, if any correction I want to make it, because sometimes it happens that it particular, like in this case, you can see it is actually in the basis slice included your wall section. And you don't want to calculate the wall related volume into your rejection fraction result. So to exclude that result, what I will do is I'll go any of my view, which is selected by LV and diastolic and systolic. Again, it is selected by the system. Okay, you can always correct it if you want it. Here I will go on the basis slice. Okay, and this particular area, right? So this area is particularly well. If you wanted to correct it, I will correct from this slice. So I'll go ahead and these all points are enabled. The moment I keep my mouse on the counter, it will give me option to correct it. These points I can, align together and keep it at once so that my segmentation and this particular correction will be in a much faster way. Once it is done, on this ROI, I do a right click. Or there's a tool called propagate counter. So you can click there. Automatically, you can see on your end asterisk also the counter got corrected. So I don't require much time here to invest. Like this is done from my end. And again, I'll see my epi counter. In this case, I will correct my epi counter again. Till here, I can able to see rest of the area. What I'll do is I'll add one more point here and I'll try to accommodate in the inner side of it like this. Okay, this always have a correction option available. Make sure this should not cross each other. Otherwise, your result will not come correct. Even system also will not give you any result. Then you can, from here in the setting, you can click on the configure BSA, which is basically you want to inform the system what is the patient height and the weight. Weight generally it is already covered because in MRI, we do require to put the weight when we are doing MR imaging. So that weight will come automatic. And moment you put all the things, your results are ready to review. Now, the time it has taken for the post-processing before, the RV is already done for your side. Now you can see here, if I go on the way, these slices, okay, your RV segmentation also done by the system, but still we do require some of the correction here because again, when I come on my basal slice for the RV, this correction always required for me. For this section, let me include and delete this phase. And then I'll come again to my other slices. Here I'll correct it. So I'll just move my mouse and the counters in a way where it will cover all the RV points. So once it is done, you can go ahead and see your result for both of the sections. That's how easy it is.
So like how in left ventricle, we are looking at the mitral valve and we know that your function and volumes will be accurate. Similarly, ideally, you should have another view in which you can actually see a tricuspid and pulmonary valve so that you know where your tricuspid annular plane is starting and you will be very accurate in your RV assessment. And believe me, all this, because we heard this, there's criteria about end diastolic volume, about these patients when they come for follow-up, those tough patients who develop pulmonary regurgitation. So many important decisions are taken on RV volumes and function. So it is very important that you take good assessment of RV volumes.
Now coming to the next part is like quantification of scar. So whatever we have seen in this case, if I want to quantify the scar here, I'll just select my spatial enhancement option. The best part is whatever the ROI you have drawn for your LV cavity, it is already propagated for you. So you don't have to redone this kind of work again on your next post-processing. So moment you load the data, as you can see here, it is already loaded all the under counters or AP counter. In some cases, let's say in this case, I can see because of the motion, the slice got added here. So what I can do is click on control. So with this method, we can able to adjust actually somehow this mouse functionality is not working in this case, but these values we can able to adjust, we can correct it, and this segmentation will done automatically. So most of the system, you do have option available with half maximum. So your whatever the intensity is coming for the scarring, the maximum intensity, the half maximum, it will take automatic. You can adjust these values to adjust the how the segmentation well done on this scar quantification. But even if you want to go ahead with the other method, that is also available for you. So once that is done, your results are updated with your enhancement percentage, the volume of the myocardium got enhanced versus the total myocardium percentage. Or you can see your transmemorality indexes. So all those maps is ready for you. Last application is your quantitative flow analysis, which is basically 2D one. If I click here and select on the IoT Q flow, I'll just open this data set again. So again, in the same workflow, I have loaded my new data sets. Here, the good part is single ROI-based segmentation, ascending aorta done. Similarly, I will select on a down. We selected yeah. Descending aorta done. So all these values got updated. And now you have option called peak ratio gradient as this. So even the gradient also you can measure with the Q flow sequences. Some articles do mention when they are mentioning the Q flow related data sets. So for the correction, if they have used any background correction in the sequence, you can use the background correction. So your values will get updated based on the background correction of your PC velocity, because a lot of static noise is there. And to correct that noise, we require a background correction. So that these are the software options you may require if you want to. If your values are not matching particularly, then you can refer to the papers if they're using these kind of tools to get the correct values, which is basically there in all the centers. Yeah. So this is all about the basic application on CNA ejection fraction.
So why QPQS? Like, we are taking flow in the aorta and pulmonary artery. Because if you want to check whether your function is accurate or not, so whatever is pumped through a left ventricle has to go to aorta. So your LV stroke volume should be equal to aorta flow. 5 or 7 ml, 10 ml maximum difference is allowed. But then you know that whether your calculations are perfect or not. So in healthy patients, LV stroke volume should be equal to aorta flow. Aorta flow should be equal to MPA flow, and MPA flow should be equal to RV stroke volume. All of them should be in similar range so that you know that your function is accurate or not. You should do that for all the patients. So when it is abnormal, like in a small ventricular septal defect or a sinus venosus ASD, you will immediately pick out that, oh, this is QPQS is abnormal, which is probably, or sometimes even in valvular regurgitation, quantification, all this is very important. And all this is without contrast. Only the name says PC means phase contrast. It is the same sequence what we use for CSF flowmetry, Argus. It is the same thing, phase contrast. It's like color Doppler, towards and away. Whatever is like white or black, only thing it doesn't to have any shades of gray. I mean, aliasing.
So whatever is coming towards it is white, and whatever is flowing in the opposite direction is black. But the thing is, you have to take care of the bank. Bank is usually 200, 250 is a good bank to obtain flows. Sometimes the velocity is very high. Then you have the teleasing, some dirty images, and then the whole sample is not homogeneously white or homogeneously black. Then you know your correction, your sample volume is not correct. If you have a wink, is something like artifact like that, then you have to increase your wink. Like from 250, you go to 300, and that artifact will disappear. So getting a good flow is important. And once you have the flow, the processing is very simple. You have to just drop a seed. System will automatically contour. You have to label. You have to label the aorta, the pulmonary artery, the descending aorta, IVC, SVC, whatever you are, not IVC, SVC mostly. Sometimes we do that. So you have to label correctly, and to label, you go to your scout images and put a matching cursor on both sides so that you know what you are looking at actually on the flow image. So just label correctly. Once you label, the system calculates all the numbers for you, and then you can use it for the report.
Cases which were given, no case one was LED viability, which was viable, and we showed you one LED viable. And second case was the MBO. That was a microvascular obstruction. So let's see if we can open that, because a few cases were not uploaded on the Philips. The third case of LV aneurysm was not uploaded. That was, I think, anterior septal wall rupture was there. MBO is there in this? Only case number 2, she said. You said 2, na? Post contrast. Where are the post contrast? I think the case is not fully loaded actually. No, but MBO. See, I showed you, I think, MBO images very well. When you see the dark enhancing thing, and inside are the hypointense areas of microvascular obstruction which were there. You're not able to open that second case.
So your software, maybe whatever you use will be different. You know, it may not have. So even if you do not struggle to, but at least understand the concept that whatever it is, wall motion, function, flow quantification, and late gadolinium enhancement. 4 steps of cardiac MR. Like how you have the entire thing for brain, and when you report MR brain or MR knee, you have a particular set. The same thing, morphologic assessment, flow assessment, and LG. So everything, all those steps should go hand in hand.
हमारे सारे loaded बटन थे इसमें भी. So can you start that? So this is, I think, I'm opening on the radiant only. Okay. So all of you can just see this was the case 2 which was given to you. And as I said in the first sequence, we look at the whole cardiac anatomy very well. And these are the basic sequences where we plan the whole study. And this is a 3-chamber view. So here we are seeing that the LA and LV are there, and here there is a hypokinesia of the inferior wall which is there. This is the RVOT view. So this is how ideally one should take a RVOT view. Here we can see the mitral valve, the pulmonary valve, and this segment you're seeing the basal inferior valve and the inferior lateral wall not is hypokinetic. So after the phase contrast, we are coming to the so this is a perfusion image. So this is how the first the contrast comes in the RV, then it comes into the LV, and then it goes into the myocardium. So there we are supposed to differentiate between a dark rim artifact. Here we are seeing a dark rim artifact, then a stress imaging when we see the perfusion defects. Now come to the this here. So this is your PSRI post contrast sequence, and this is the MVO which we are talking about in the inferior this lateral wall. So here this is a hypo area, the hypointense area surrounded by the hyperintense rim. So this is what we are talking about in the LCX directory, that this is MVO. And as I said, these are seen in the acute infarction and not a very good prognostic sign. We are seeing some enhancement here in the inferior septal wall as well. So this is how we do in the viability assessment. And the third case was your So this is the mitral valve. I'm doing the short axis cine. I'm going from base to apex. And here we are seeing this anterior septal wall and anterior wall is kind of ruptured. Focal aneurysm formation is there.
So that is how dyskinesia would look like.
This is in the two-chamber view also. Please close down the lights. So here we can see very well this akinetic focal aneurysm formation along the anterior wall, which is seen. Lights band kar do, please. This is the four-chamber view, cine, showing the same. Since it's anterior wall, it will be seen very well in the long axis and the short axis. Now we need to see how much is a viable myocardium in this aneurysmal segment and how much is the thickness. So thickness we will see in the your normal cine, and this is the enhancement, that almost transmural enhancement is there in this segment. So this is non-viable myocardium in the LAD territory with a aneurysm formation. That is a complication which is there. And we are supposed to see at the neck of the aneurysm, how much is the neck, how much is the size, are there any thrombi in it or not. So all those things and the segment ratio have to be calculated. I think this is fine. Viability, the rest. Thank you for closing the lights.
I'll show the rest of the cases. Now we have learned how to do a processing on the software. Some of these cases are not imported into the Philips system, so I'll just use the radiant to show them. Basic diagnosis of all the technologies can be made on a radiant viewer. The use of the software is processing, calculating the volumetric and the use of software is processing, calculating the volumes, EF, star score and all that kind of stuff. So if you do not have a software, do not let that stop you from doing any cardiac imaging. Just a minute, it was. Is So this patient, we start from the scout image. So we see this is the axial scout. Okay, let me. That's a SAD scout, coronal scout, and axial scout, as we discussed. Now the second was a black blood image. It is black blood because it is the blood is black. Now on this image, what we are seeing that there is some degree of fluid in the lungs, both pleural effusion. There is some patch areas of signal abnormality in bilateral lungs, probably some pericardial edema. There is also some pericardial effusion seen. We can also see on these images there is some hypertrophy. Now from that, we made a two-chamber, the chamber, then a localizer for this is a four-chamber. There is also some thickening of the mitral and the tricuspid valves. The LV function was okay. When we calculated the software, it was around 50%, and you have pleural effusion. So pericardial effusion. So bilateral LV and RV and bilateral enlargement in the patient with maintained EF. You know you are looking for amyloid. So that is a short axis. So on a short axis, on limited to the right atrium, that is what your report will say. Limited to the right atrium, not involving the tricuspid valve, no extension into the RV. On perfusion images, the periphery of the lesion picks up mass, but there are central non-enhancing areas. And even on a post-contrast image, there is peripheral contrast enhancement noted, but central non-enhancing areas. All these findings are in features of a neoplastic mass, likely sarcoma. And then you have to advise, obviously, a histopathology. And this is a proven case on histopath. Okay. Now, this is my last case, and this case was selected as a semi-finalist in SEMR best case category. So this was a 54 years old male patient who came with some pericardial effusion on echo. Now, I don't know why did they got a CT angio done at that point. We did not know anything about the patient. The cardiologist told us to do a CT angio, so we did the same. And on a CT angio, we see there is a large pericardial effusion, but also there seems to be these loculated cystic sort of areas. And if you look at the coronary arteries, here the mass is sort of encasing the LM and the LAD, and the LCX here appears to be sort of mildly narrowed. Otherwise, it looks like a weird benign cyst, maybe benign or low-grade cyst at this point of time. We do not know benign. Benign is not the right word. But the cyst is not showing any particular enhancement on CT image. So we advise that this is a mass and the patient should actually get a MR to better assess it. So we did a MR, again a scout image, a black blood image showing you large cyst with some complex fluid, pericardial effusion, this cyst with septate. Then a cine image is the short axis stack. So you see this cyst, that is the LV which is contracting, that is complex pericardial effusion, because I'm saying complex because if it was simple, it would show T2 bright. It is showing some dark areas. LV is contracting well. However, if you look at the lateral wall, this looks dull, especially if you look at the mid segments, I'm sorry. So the basal segments look fine. But as you come down to the mid segments, this is bad. So let us come back. You can see these cyst, multiple cystic lesions. Again, you see here, this starts getting hypokinetic. This area is hypokinetic, is also thinned out. Rest of the whole of the LV is functioning fine. This wall is bad. Otherwise, RV is fine, LV is fine. Echo was saying normal. We calculated on our software, it came 52. Again, a 4-chamber stack showing the same. This you can see cyst. This is diffusion. These are some cysts. And these cysts are sort of like interconnected, but they are involving the whole of the myocardium, extending around the myocardium, also extending along the left AV groove where the LCX is supposed to be sitting. And again, the lateral wall is dull, is low, functioning not well. That is a T1 image. That is a T2 image, not very great. Now, that is a perfusion image. So that is important. On perfusion, none of these cysts took up any contrast. So it essentially rules out that it is not a malignant neoplasm. And it is not a thrombus, obviously, for its lesion. It is pericardiac. That is nothing. And now let me show you the PSIR images. So on a PSIR image, we see a transmural, near transmural scar in the lateral wall. But these cysts actually do not show any enhancement. So these are actually cardiac hydatid. They are a very rare sort of presentation for hydatid disease, but they do occur, especially in a country like India. And this case was actually scanned at SMS hospital. And this transmural scar is secondary to LCX involvement. Now, what happened was, because of this inflammation secondary to cardiac hydatid, there was some degree of narrowing of the L6 as we saw in angio done previously. And this probably contributed to some of it. And some of it is also secondary to the inflammatory response, secondary to cardiac hydatid disease. So this is cardiac hydatid with pericoronary involvement and a transmural scar, near transmural scar in the LCX territory, secondary to some LCX narrowing. If you want and you're interested, you can read more about this case on SCMR website. It's free to read for everyone. Now, if anyone has any questions, I would like to take them now. It's already 4:15 and we are almost closing. Then please have some tea before you leave. Thank you all for being here. Thank you all for coming.
your understanding, then better